valuable attention. Chairperson, today I am going to present a case report of an unusual international foreign body which was diagnosed and treated under the guidance of Dr. Leaders, Associate Professor, Assam Medical College Hospital. Next slide, please. So this is a case of a civilian accidental firearm injury in the facial region which occurred in 1985 with a history of lodgement of foreign body pilate in the posterior part of the nasal septum and the right eye. And during the blast, the pilate penetrated his nose and right eye, resulting into and lodges in the posterior part of the nasal septum and the right eye, leading to destruction of the right eye and perforation in the posterior part of the nasal septum. Next slide, please. Next slide, please. So our patient was a 39 years male teacher presented to us with complaint of foreign body sensation in the nose, right side more the left side, and persistent nasal blockage, right side, and complete loss of vision right side since accident. He also complained of complete loss. He also complained of occasional blood-stained mucopurulent discharge and frequent attacks of rhinitis and headache for 5 months. Next slide, please. On examination, we found a scar over his right lateral wall of the nose, which was extending from the medial canthus to the nasal labial fold. His right eye was collapsed. On indirect craniometry, there was bilaterally partially blocked nose, and anterior endoscopy shows Becky's foreign body, which was impacted in the posterior part of the nasal septum, occupying both sides of the nasal cavity, and there was hypertrophy turbinate on the left side. And both the maxillary and frontal sinuses were tainted. Next slide, please. So all the preoperative investigation like routine blood, urine, PGCT, ECG, chest X-ray were within normal range. Next slide, please. We have gone for the X-ray paranasal sinuses. This is the X-ray PNS, so it's rounded, ill-defined margin foreign body impacted in the nasal septum, which has eroded the septum occupying both sides of the nasal cavity. Next slide, please. We have also gone for the CT scan nose and paranasal sinus. This is the sagittal and the actual view of the CT nose and paranasal sinus, showing a metallic foreign body in the right nasal cavity, eroding the medial wall of the right maxillary sinus and pushing the nasal septum contralaterally. There was collection in the right nasal cavity and also a low dense collection in the left maxillary sinus. Next slide, please. So we did the nasal endoscopy. It shows the irregular bony heart raised foreign body seen in the posterior part of the nasal septum, which was occupying both the nasal cavity. Next slide, please. So the treatment was done surgically. So under all aseptic and antiseptic conditions and under conventional general anesthesia, foreign body was disclosed under endoscopic guidance towards the nasopharynx and removed perorally, as the foreign body was tightly impacted with the floor of the nasal cavity, and after repeated trials it was not possible to remove it entirely. After removal of the foreign body, the bleeding points was, the proper hemostasis was achieved by diathermy, and intranasal packing was given, and proper antibiotic was given, and ANPA was removed after 48 hours. Next slide, please. So this is the intraoperative endoscopic view of the removal of the foreign body. Next slide, please. So this is the immediate postoperative view of the foreign body, which was blackish in color and rounded. Next slide, please. This is another view of the foreign body showing dimensions. This is 3.5 cm in diameter and 1.5 cm in thickness. Next slide, please. So coming to the discussion, with the increasing use of the firearm in the society, there is significant rise in number of the homicidal and suicidal injuries, but the accidental injuries are also not a rarity. Gunshot injuries of the face and neck vary in extent and the significance, forming a spectrum from a trivial injury to the life-ending relations. Firearm injuries in the head and neck regions has a great potential to leading a fatality in event of trauma, as there are many vital structures are confined in a very small area of the body. Next slide, please. So coming to the conclusion, we have presented the case because of its unusually long duration and its rarity. Though the injury was grievous, resulting in the destruction of patient's right eye, patient presented to us late because of his financial constraints, and also his nasal symptoms were not severe, as the foreign body was impacted in the posterior part of nasal septum, occupying only half of his nasal cavity and leaving half of the nasal cavity. Thank you, sir.
Thank you, Dr. Prasad. Next, I request Dr. P.M. Barua. You will be permitted 8 minutes, please.
respected chairperson, co-chairperson, and ladies and gentlemen present. The topic of my subject is barium swallow versus upper GI endoscopy in dysphagia. My experience. Next please. What is barium swallow? It is the conventional radiological examination of the esophagus. Here, patient swallows a suspension of barium with concurrent radiography of the neck and thorax is taken. Next. What are the aims of barium swallow? The barium swallow is done to study the disorders of the swallowing, to study anatomical abnormalities of the esophagus, to study diseases of the esophagus. Next please. Radiologically, esophagus has three parts. One is the upper esophagus, which constitutes hypopharynx and cervical esophagus, thoracic esophagus, and number three, the region around the esophagogastric junction. The barium has some advantages. These advantages are, number one, it is an inert substance. Number two, it is less irritating than the other water-soluble contrast. Number three, practically it has no chance of hypersensitive reaction. Number four, it provides better radiological details as it is radio opaque. And lastly, it is economical. There are some contraindications of barium. When there is chance of spillover of barium into the trachea occurs, as in tracheoesophageal fistula and neurological disorders. We have some common problems, and what usually we do. Dysphagia is a common problem faced by all the ENT specialists present in this August House. Without detailed investigation, it is very, very difficult to come to a proper diagnosis. When indirect laryngoscopy is no abnormality, we advise the patient to undergo barium swallow and chest X-ray. And if the barium swallow and chest X-ray reveals no abnormalities, we the ENT surgeon take the case lightly, and we give the conservative line of treatment. The study was conducted at High-Tech Polyclinic and Diagnostic Center, Guwahati. 40 patients who had persistent dysphagia even 1 month after normal barium swallow X-ray and chest X-ray were taken for the study. The study was conducted from April 2003 to March 2004. We used Pentex upper GI flexible video endoscope, and the procedure was done under local anesthesia. All the 40 patients, they were subjected to upper GI endoscopy. Next, please. We have very interesting results. The patients who had normal barium swallow, in our series, we found that malignant growth of esophagus, 10 cases, 25% cases, huge number of patients. Though barium swallow is normal, we found in 25% of the cases, there is growth esophagus. Then, in 20%, we have GE collapse. In 15%, we have GIT. In 5%, we have esophageal polyp. In 2.5%, we got esophageal diverticular. Of course, in 32.5%, there is no significant findings in the endoscopy. Next, please. These are the cases of CA esophagus. In the CA esophagus, in 25%, majority of the cases were very small, less than 1 centimeter. But in one case, this is a rare case where the growth is quite big, but surprisingly in the barium swallow, we didn't find any findings. Next, please. This is a photograph of the GE collapse. Next, please. This is a photograph of GERD. Next, please. This is an esophageal polyp. This is a magnified view. So, importance of basic technique of barium swallow. They are to include cervical esophagus in the barium study. Usually in our practice, what we do is just take the picture of the thoracic esophagus only. So when we should advise that it should be barium swallow except the pharynx and esophagus. Number 2, for cervical esophagus, 1 epi and 2 lateral views should be taken to exclude web or diverticular. And number 3, for lower 1/3 of esophagus and G junction, fundus of stomach to be included in the same thing. There are some modifications of the basic technique of barium swallow. There, by varying the consistency of the barium, we can evaluate the swallowing competence and identify thorough laryngeal penetration of the contrast agent. Number 2, air contrast granules, that is the double contrast barium, may be used to distend the esophageal lumen for visualization of the subtle mucosal and submucosal lesions. And number 3, VFSS, that is the video fluoroscopic swallowing study in presence of speech language pathologist or radiologist trained in swallowing physiology gives more information. So in conclusion, I come to the following points. This is a simple looking lady. She is an Iraqi lady sitting in a street of Baghdad. One baby is there in her leg. But she was not simple. She was a member of the Suicide Squad. Bombs were fitted to her body and to the baby. She triggered the bomb, killed herself, her baby, and 42 US soldiers. So just like this Iraqi lady, normal looking barium should not be ignored. Next please. This is a gold standard investigative device. The upper GI endoscopy is really gold standard because it is simple, safe, OPD procedure without GA. It is economical and biopsy can be taken. Next please. This is a middle-aged man. He looks normal, but to US Army he was not normal. He was suspected. They arrested this gentleman. They immediately do the DNA test, and they found that this gentleman was no other than US the President Saddam Hussein. So, with the ENT surgeons, when we do have any doubt, just like DNA test, we should immediately go for, though the barium swallow is normal, just like DNA test, immediately we should go for either endoscopy or the other investigative devices. It makes the diagnosis easy and early. So with these few words, I conclude my very short and simple talk. I thank all the audience present here in this historical city of Shivsagar. And last but not the least, I must thank this God. He is the Dhanantari. He is the God of the physicians for his blessings in preparation and presentation of this small paper. Thank you very much.
Thank you, Dr. Borua. With this, we have concluded the first session of scientific paper presentation. Now the house is open for discussion. Before calling invitations from other dignitaries, I would like to comment on Dr. Mukherjee's presentation. He presented with developmental joint arthritis. I'd like to recall the days when we had a conference at Assam Medical College, wherein I presented 2 cases of such TM enchylosis. One was having urinary problem.
So with this we have come to an end of the initial free paper session. We'd like to begin the formalities of the inaugural session now. Honorable Minister of Transport, Shri Anjan Datta, and Executive Director of ONGC, they are already here. I will be starting the inaugural meeting very soon. Thank you.
Thank you, sir. Assam Asset. To the stage to be escorted by Dr. Pradeep Burman, Joint Secretary, Organizing Committee. we request Dr. Udayaditya Rajpur to escort Secretary, Nebaoicon, Dr. S.N. Mukherjee, to the dais to grace the occasion. Thank you, sir. Thank you. To escort Dr. Saurabh Kumar Gogoi, Organizing Secretary, Nebaoicon 2004, to the stage. Thank you. Our country, that is India, is a mixed bag of cultures and religion. In every religion and culture, we treat our guests as God. Following this tradition, let us invite Dr. Mrs. Anjana Bardale, First Lady of the Organizing Committee, to felicitate Dr. Mrs. Prabhati Purkayasa, President, Nebaoicon. Dr. S.N. Mukherjee. Thank you. Thank you. Sri Anantai. Our senior most citizen of Sissagar, Sri Rita Prasad Barua. I request Thank you. Thank you.
लखनऊ में से पहले आप I extend you a cordial welcome to all participating delegates to the historic town of Srinagar, once the capital of Assam during Ahom Kingdom. I am hopeful that you all shall enjoy a comfortable stay here and enjoy the traditional hospitality associated with the Assamese people. The profession of medical science is so vital that cannot be ignored by anyone living. It cures and heals the ailing and provides solace to the sufferer. I take this opportunity to pay my homage to those eminent persons whose pioneering research efforts have transformed the entire gamut of medical science. Though there have been tremendous achievement in the field of medical science over centuries, the challenges ahead are also mind-boggling. Today, some very terminal ailments like TB, cancer, have been rendered curable, and nothing can be more joyous and wonderful than give a renewed life to the sufferers. Critical medical procedures like liver transplant, kidney transplant are carried out with relative ease. It is due to this that doctors are often equated with all supreme God. By knowledge and skill, all doctors are developed countries. I optimistic auditions, papers and life surgeries so it can assist them to upgrade their professional skills. It is commonly seen that eye camps are very popular everywhere, and much emphasis has been laid in this arena by all concerned. Our ENT fraternity should also strive to make deeper inroads by involving voluntary agencies like Lions, Rotary, or local organizations to bring about the general awareness of the ENT. General awareness of the ENT from two shall encourage and assist any such ventures by anyone amongst you. I would also like to take this opportunity to call upon the distinguished doctors to come forward to help the poor and needy people. Shall it not be wonderful if the super specialty doctors who are not in government medical service make it a resolve to render free medical service to at least a couple of poor.
But unfortunately, if we see the health development index, we don't stand at the top of the list. The health care facilities in our district is not in good shape. Accessibility to the better health care, quality health care is not there. As you will appreciate that government machinery is not capable and not well equipped to deliver the quality health care. Therefore, the people look towards private system or private health care care delivery system. And this workshop, this organization event is quite contextual, and I'm hopeful that you will deliver not only the technical part of the medical science and the recent development in the ENT sector, but also you will develop the social aspect of the health system. As Honorable Minister has pointed out, that it would be pertinent if you feel and you owe responsibility, social obligation to care for needy and poor people who are marginalized, disadvantaged. I hope that these things will be discussed in the conference. I express my best wishes, good luck for the grand success of this event. Thank you very much.
Thank you.
From which I am speaking this morning, that in the premises of ONGC, we have had the opportunity to get you all by the cooperation and support of the Srinagar ENT Academy. We are indeed grateful for you all to have chosen this as a venue. Doctors have been compared with God, because God saves your life and so do the doctors. And so when they all decide to converge on a place, the place has to be blessed. And so I consider myself blessed. I consider my organization blessed that you are here today. I am confident that my people will be able to look after you well during your stay. As also I am confident that you will love and admire the cultural heritage of Assam. In fact, I was reading a quote from somewhere that by remaining where we are, we cannot become what we want to become. So if we want to become something different than what we are today, we cannot afford to remain the same. So this pursuit of knowledge and excellence has to be ever embedded in each one of us. And such kind of conferences, seminars and get-togethers go a long way in keeping that promise, in enlightening that fire within the people to become different from what they were until yesterday, to become better, to go a step further in the pursuit of knowledge and excellence. I am sure this conference will enrich doctors of ONGC as also of doctors of the Northeast by exchanging views with eminent doctors from all over the country. And from within Northeast, eminent doctors who have assembled, they will exchange their views with their fellow doctors and will enrich enrich them knowledge-wise, and this will greatly benefit the humanity at large.
I'd like to request the audience to give a standing ovation to the Thank you, sir.
At the outset, I express my sincere thanks and gratitude to Dr. Bordway, President, and all the members of the organizing committee of the 70th Nebaoicon, and all the members of the Academy of Young Servants of Srinagar for bestowing this honor by felicitating me on my platinum year on this auspicious occasion in the historic city of Assam. I deem it a proud privilege, although I am not worthy of it. I have been associated with this specialty for the last 47 years and with the association since inception. But I think my contribution is very insignificant. We are here to learn, we are here to contribute. I feel it is our bounden duty to contribute till we live as far as practicable, not only to the society, not only to the speciality and the association, but also to the society, because we have to live in the society. With these words, again I thank all the members of the organizing committee. Thank you, all the guests.
to Secretary Nebaoicon, Dr. S.N. Mukherjee.
I am pleased to inform you some of the themes of activities of our Nebaoicon. Though we are lacking in infrastructure in Northeast, but we don't lack in enthusiasm. And under the dynamic leadership of our President Prabhati Professor, we had workshop first in downtown hospital. That was by Professor Dhaka immediately after the last conference in Guwahati Medical College. Then we had microsurgery of the ER workshop at Nightingale Hospital. That was conducted by Dr. Nebaoicon. And then we had microsurgery of the ER workshop at Nebaoicon Hospital. That was again conducted by Professor B.K. Raichaudhuri. which was well attended by delegates over there. We had diagnostic workshop at Center Medical College, which was conducted by Professor P.S. Saria, and it was well attended. Now, I believe that this association has to strengthen up more. We should have more of the live members, then we should abolish the ordinary membership. Altogether, we should have live members or associate members. Each should be in the beginning associate members, subsequently they will become live members. We are pleased to inform that we had a very nice workshop yesterday. That was by our guest faculty, Dr. Pudul Hajarika, as well as Dr. Mohan Lamishram. And that was, everybody, delegates must have enjoyed that. Now, deafness is a national problem, and if public awareness is mandatory, and we should organize more the free ear camps so that we can detect the early deafness cases, and we must condemn the noise pollution, which we are actually we should have sort of noise-free zones in different areas so that we protect our ears of the patients. We have high sense of malignancy in head and neck region. We must raise public awareness regarding the deaths and disease. I feel more frequent health checkup and cancer detection has to be organized so that we can detect early cases and help them. The aim of our association is to enrich ourselves with academic as well as practical hands-on training so that we can offer better service to our patients. I wish Nebaoicon 17 a great success. Long live Nebaoicon. Long
live. And cooperation from all the members of our noble association. I acknowledge with gratitude the honor and attention I receive as president. This distinction I enjoy with some burden of responsibility, which I try to fulfill to my ability. Our association has the distinction of uniting 7 sister states of northeastern India and bringing them on a common platform. We all may not look alike, weigh alike, or speak alike, but we certainly think alike in matters about their association. We really do. That is why every year we feel that irresistible urge to meet in an annual conference, to exchange our views. These annual scientific meets are all about giving something and receiving in plenty. The message has sparked time, and so the trend has already been set. Now we find ourselves organizing 7 workshops, CME programs every year. There is no trace of doubt that the standard of autoradiological service in the northeastern state has gained momentum for the last couple of decades. It is almost at par with that of the other part of the country. We cannot overestimate the role of conference, workshop, CME programs, etc. The overall improvement has gained great impetus to teaching and training of otolaryngology in our region. The budding otolaryngologists and the newcomers and even the veterans in this specialty are now being constantly exposed to a number of scientific workshops and are remaining aware of the changing scenario of our specialty. We can see great surgeon work, can hear from them directly, and can even interact with them. It has been a boon to the ENT education as a whole that has been ultimately translated to the benefit of common people. Here I must acknowledge the help and cooperation. One of the prerequisites is social awareness. Simply as a responsible citizen too, we may of course have a part to play in it. However, we have our major role to play in performing our duties as physicians in treating patients to the best of our ability. Treatment in the truest sense should be discharged not only with professional care and clinical efficiency, but also with honesty, sincerity, and a humane touch. Along with a thinking head and skillful hands, we should develop a compassionate heart too. There is a beautiful saying in English, a true measure of your worth includes all the benefits others have gained from your success. We have a lot to give to our society, but only a lifetime to live. Certain changes in our attitude will ensure more deserving beneficiaries within the service net of modern medicine. I have completed 1 year as the president of Nebaoicon. It has been a wonderful experience, as I have already said. I am happy that I shall possibly charge of my office to one of the most capable and respected ENT teachers, Dr. Mrs. Kavita Barua. She will be our next president. I cannot think a better person than her to adorn this chair. There cannot be a better venue than this glorious historical place of Assam to hand over the charge of president. I am certain she will lead us to a more bright and glorified tomorrow. I wish again success to our conference. Long live NBOI, long live the spirit of our association. Thank you.
Good morning, everybody. Respected dignitaries and the dais, Mr. Paikan, Mr. Javedi, Mr. Doctor, sir. But with rain, now we have completed another good year of performance in Nebaoicon, and I congratulate all the office bearers and the members for that. You have honored me by giving me the chance to head this August association. I am feeling a bit uneasy to accept such responsibilities which was so efficiently handled by my predecessors, including my beloved friend Dr. P. Purkayester. However, I am happy that I have to accept this honor at Sivsagar, a place that holds in store a lot of historical values. Sivsagar is the capital of Ahom Kingdom, as you all know, having a lot of ancient temples and monuments, and which shows and bears the stamps of glorious Ahom period. Moreover, Sivsagar is my native place. My both parents and mother-in-laws hail from Sivsagar. I feel happy to recall my childhood days, flying from Dibrugarh to Sivsagar to meet my grandparents. I am thankful to my teachers and to my ENT colleagues once again for electing me the president of the August Association for the year 2004-2005. This is the platform where we all discover ourselves to be very united and heartily exchange thoughts and experiences. We are aware of the glorious past of the association, and we all know how much we the association depends upon the office bearers to fulfill our desire. Therefore, I hope with all our strength and ability, all of your valued support and guidances, we can fulfill our dreams. Nobody can say, I did it. We have to say, we did it. Now we all have to plan how we would be able to serve our people better. I appeal to our esteemed young members to accept it as a challenge to see if further improvement in the quality of service can be extended. All efforts should be made to produce better quality research work by undertaking different schemes and projects. They are fortunate, my junior members are fortunate to have most of the latest advanced technologies in hand in the very early phase of their training courses, which were only theoretical and dream for us during the study period. So, they should take full advantage of their fortune and make themselves expert in different fields of otolaryngology of their choice. I would expect that they would occupy a high position in the field of otolaryngology of India or even better. With these few words, I thank all of you and welcome you all. Thank you.
Dr. Mohan Kameshwar, Dr. Barin Rai Chaudhary, Sida Sir, distinguished guest present here, and senior ENT surgeons Sida Sir felicitated today, delegates present, all the doctors of Sibsagar who are the members of this reception committee, and members of different commercial houses, technical personalities. Yesterday we had a very nice workshop, and at the end of the day we got that sorrowful news that Pradul Hazarika, the distinguished guest surgeon's mother, passed away. We had a condolence meeting today. May her soul live in peace. While thanking, first of all, I on behalf of the organizing committee would like to thank Honorable Minister of Transport and Industries, Sri Anjan Datta. I would like to thank him for coming to inaugurate this conference, and you know Sri Datta as the most young, energetic, popular, dynamic leader. The success story of ASTC is now a legend. He changed ASTC overnight. And I sincerely hope and pray one day that he become the Chief Minister and the story of ASTC repeats as Assam story. And I pray to God for that. I would also like to thank Executive Director of ONGC for allowing us to use this venue and releasing the souvenir. He deserves a special thanks for rescuing us from a very precarious condition, which I would not like to elaborate, but thank you all the same for it. And Sibsagar being a very small township, there is not a compact venue in this Sibsagar town, and this is the only relatively chalta hai type of a auditorium where we can have a conference, and thank you for this. I also like to thank the Deputy Commissioner individually, but physically and mentally too. I would also like to thank all the doctors and other workers of this district who have worked days and night for the success of the conference. And that's all I have, and thank you. And those coming 2 days, we will have, I will probably have to say many times thank you, but then I'm really thankful that you have all made it to Sibsagar despite everything, bad weather, bomb scare, and thank you very much.
He is a fellow of International College of Surgeons and a fellow of Tamil Nadu Academy of Sciences. He is also designated overseas clinical tutor of Royal College of Surgeons, Edinburgh. He is the founder president of the Cochlear Implant Group of India. He was formerly an associate professor of otolaryngology in Shaw University, Kingdom of Saudi Arabia. He has edited a textbook of ENT diseases in a tropical environment and 2 dissection manuals, one on temporal surgery and the other on skull-based surgery. He has contributed a chapter of screening for otolaryngological cancer, a textbook edited by GYW University of Connecticut Health Center, School of Medicine, Peninsula, USA. He also has 50 publications in international and national journals. He is the winner of several gold medals and prizes. and gold medal for the best outgoing student in MS for the year 1981. And Chipperfield gold medal for surgery. He is one of the pioneers of cochlear implant surgery in India. He is an examiner of painting for several universities in the country. He regularly conducts workshops on temporal skull-based surgery, heart surgery, audiology, orthodontics. I have no words to welcome Dr. Kameswaran. Hope all of us will be benefited from his deliberations. I welcome you, Dr. Kameswaran. Thank you.
Thank you, Mr. Chairman, for those very kind words. Mr. Chairman, Co-Chairman, Honorable President, President-elect, distinguished members of the Nebaoicon, Professor C. Das, Roy Chaudhary, senior and junior colleagues. Let me first of all tell you how privileged I feel to be here, to be in this beautiful and historic sacred city of Shivsagar. I've read about it even before I had the opportunity to come here. I'm also very grateful to you for inviting me to this most beautiful part of this country. Yesterday when I landed in Dibrugarh and drove to Shivsagar, I was admiring every inch of land. For a man who comes from a very water-starved city, it was a very pleasing sight for my eyes. So it's a great pleasure to be here. And I also want to tell you that we bring greetings to you from the south, from Chennai. There is so much in common. Your love for your language, your culture, the very soft manners and mannerisms of the people of the Northeast. We share the same tradition in the south. And even the food which I had yesterday was so much like the food I have back home. We are also rice eaters. And I believe sincerely that rice eaters are cleverer than wheat eaters. So I'm really delighted to be here. Now I have chosen a topic which is a little out of the way. Not because I want to sound high-tech, but because there are some real problems in the airway which are not very easily solved by conventional methods. And it is necessary for us to start looking for tools which help us to get over these issues. When I bought my KTP laser, it was about 7 years ago. It cost me at that time almost 50 lakhs. Most people, including my wife and my father, thought that I was out of my mind because it would be the cost of 2 Mercedes-Benz cars. But I stuck to my grounds. The reason why I did that was simply because when I was a very young registrar in London, my boss told me once that as soon as I finished my first year, he said, now that you're a surgeon, let me tell you a piece of advice. He said, as a surgeon, look after yourself. Make sure you're comfortable when you're working. And indulge yourself into things that you think are going to make your life worthwhile. Because if you don't look after yourself, no one else will look after you. I think it's very good advice that I got. And I felt that loaded with problem cases in the airway, as I do even now, I had to have means to help me overcome them. And I shall share with you today some of those difficult problems and some of the difficulties that I faced and I still face. Laryngottracheal diseases of the upper airway, can be extremely challenging, and we all know that. Of course, endoscopic methods have been with us for several years, and they have several advantages over external procedures. And lasers have proven to be very useful. What many of us may not know is that lasers was first introduced in surgery in the specialty of otolaryngology. For some reason, we did not continue with that. It was Dr. Stuart Strong. I'm sure Dr. Das would remember him. He had come to deliver the Joshi oration. He was a pioneer of introduction of carbon dioxide laser. And as a matter of fact, the carbon dioxide laser was first developed by an Indian, Dr. Kumar Patel. And it was this laser that was first introduced into surgery. Well, the ENT surgeons slept, and other colleagues surged ahead. Ophthalmologists and general surgeons, plastic surgeons, all of them started using it, and using it in a big way. And only very lately, after nearly a gap of 20 years, that we again woke up to the reality of introduction of lasers into our specialty. But I'm glad to say that we are now more than trying to compensate. What are the lasers which have been used in the upper ear? There's a wide variety of lasers to choose from. And briefly, these are the lasers which have been used. The KTP532 laser. KTP stands for potassium titanyl phosphate, a crystal through which a routine Nd:YAG laser is passed, so that its frequency doubled. By passing an Nd:YAG laser through a KTP532 crystal, it is frequency doubled. It has several advantages. The laser becomes an extremely efficient cutting tool. It becomes an excellent coagulator. So it's without doubt the Mercedes-Benz amongst lasers, even though it costs like a Mercedes-Benz. The CO2 laser is an excellent cutting tool, but not a very good coagulator. And it suffers from one big disadvantage, and that is that it cannot be passed through optical fibers. It has to be passed through a system of reflecting mirrors which are cased in an articulating arm. For that reason, the delivery system becomes bulky, and you cannot use a laser below the vocal cords because you need to have a flexible fiber below the vocal cords. Nd:YAG can be passed through optical fibers. It's a very good laser for coagulation, but it's an extremely slow laser for a cutting tool. So it's a slow laser, and for that reason, it's not preferred in the airplane. Diode lasers are now coming into vogue. They are reasonably priced. They can be passed through optical fibers. They are good cutting tools. They are good coagulating medium. But the only problem with diode lasers are that they are imprecise. There is a lot of collateral tissue damage with diode lasers, and therefore when you are using it into very fine areas like the ear or in the vocal cords, you can do more damage than you want to do. So this imprecision we still have to get over with diode lasers. The tunable dye lasers are a step in the future. What we're trying to do in this is that you have a system of dyes and you pass a light beam through it to get a laser beam coming out. And by altering the dyes, you alter the wavelength. So it's like tuning a radio to get different stations. But it's not yet commercially available, it's experimental. But we do hope it's going to come in the future. So I already said that KTP532 laser is a frequency double Nd:YAG laser. It's a visible laser. You can see the laser when you're working. So it's a great advantage. The CO2 laser is an invisible laser. Whereas here you can actually see the laser working. So you can see it in real time. There is very minimal collateral damage. It's an extremely precise laser. And above all, the wavelength of the KTP laser matches the frequency absorption spectrum of hemoglobin. So when you shoot the laser into a field, a surgical field, it is absorbed by hemoglobin selectively, which means that you will concentrate the laser at the points which are bleeding selectively. So for that reason, it's a very good coagulator. It can be used in different modes. It can be used in the contact, near contact, or non-contact mode. What I mean is, you can actually touch the tissue with the tip of your laser fiber when it will cut. It's a contact mode, it's a cutting tool. If you take the laser fiber a few fractions of a millimeter away from the tissue, it's a near contact mode. In that case, the same laser will vaporize the tissue. Like the third eye of Shiva, it will vaporize the tissue. If you take the same laser a few more millimeters away into what is called a non-contact mode, the same laser becomes a coagulating laser. So by varying the distance, the incidence distance, you can vary the function of the same laser without changing any of the settings. That's a great advantage for the surgeon. So it's a good cutting tool, a coagulating laser, can also vaporize tissue. So it's therefore the laser of choice for the airway. Now what are the advantages of using a laser in the airway in the first place? It's precision. You want to work with So that's the laserization of a hemangioma and what happens, what it looks like after laserization, 15 days post laserization. Now that's a small video just to show you that's the hemangioma seen through a direct laryngoscope. And that's the laser being applied to the hemangioma. Now what happens is when you use a laser on a hemangioma, you have a phenomenon of implosion, which is exactly the opposite of explosion. The tissue collapses and vaporizes. So you keep the laser in one point and the surrounding hemangioma just falls into the same area and gets vaporized. It's almost like a self-suicide by the hemangioma. And you lose no blood. So you can avoid a blood transfusion and you vaporize extremely efficiently the hemangioma, sparing the surrounding tissue. So it is a real delight for the surgeon. You can go into nooks and corners because, as I said, this is a fiber optic probe and you can go around corners with the same laser and laserize the tissues that you want to, in this case, of course, the hemangioma. So it's a great tool. That's the epiglottis. You can all see the epiglottis there. And I'm working in the vallicula. This is the regional vallicula. It's a large vallicular hemangioma. Below that is the vocal cord, which is perfectly normal. So this is an obvious advantage of using a laser in a difficult airway problem. So after 15 days, just an endoscopic view shows the fibrosing hemangioma. There's no more vascular lesion, it's all fibrous tissue. That's the epiglottis, which is rudimentary now after the laserization. Now in the larynx and trachea, for benign lesions, the laser can be used comfortably. It adds to the comfort factor of the surgeon. But I will not say that it is absolutely essential to manage this lesion. Because we were managing before we had the laser, we still continue to use conventional surgery for these lesions. But there's no doubt that it greatly enhances your capability in managing these problems. And particularly if you are working on people who are particular about their voice, Chennai happens to be the capital of Carnatic music industry. It's a huge industry, and we have millions and millions of rupees spent on these people. Their voice is in a premium. We have a huge film industry as well, and periodically we get these singers who come with these kind of lesions, and precision and voice conservation becomes absolutely essential. Lasers become very useful in such a lesion. Now, that's a vocal nodule. It's bilateral. The laser here is used not to cut but to shape. Because what you do with the laser is you don't burn the nodule. You just take it layer by layer, like peeling an onion. So you just take off layers of fibrous tissue till you have the margin of the vocal cord preserved exactly as it were. In my center, we have a voice laboratory. We have a stroboscope, and we use the stroboscope for assessment of these patients, both preoperatively and postoperatively. And we have no doubt that when we use a laser in these lesions, our vocal cord mobility, the fold mobility, is preserved much better. So therefore, there's no doubt about it. That's a vascular hemangioma. And you can again see how the laser can work with very minimal bleeding. And you can have still bleeding. I don't want you to have the impression that laser is absolutely bloodless. Lasers coagulate bleeding from vessels which are less than 0.6 millimeters. Bigger vessels will still bleed. Yeah, but you may have to deal with them by other methods. But at least you are dealing with all the small vessels and the small bleeders. So therefore, this is a good example of how a vascular hemangioma is dealt with. I'm just shaving it off, not just shaving it off, I'm just cutting the pedicle. But remember, if you laserize a tissue, that tissue is useless for histology. So if you want a biopsy of a lesion, do it before you use a laser. Once you laserize the tissue, it loses all architecture. The pathologist can only see a lot of scar, a lot of ash and burnt tissue. So you will not be able to get any meaningful histological diagnosis from a laserized lesion. Difficult problems like a web, for example, a laryngeal web. Now this is one of the very good indications for using a laser. Maybe congenital or acquired. And here, what I'm doing is, first of all, trying to release the web. This is very efficiently done with a laser. The advantage of using a laser in a web is very simple. Lasers induce very minimal fibrosis. The reason why they induce minimal fibrosis is simply because they induce very minimal inflammatory reaction. And when you have a very minimal inflammatory reaction, fibrosis becomes minimal. So when you're dealing with a scar tissue, be it in the vocal cords or in the trachea, as in tracheostonosis, the advantage of using a laser is that you are excising a scar but producing much less scar after that. So that's the main advantage. Now here, after I release the vocal cords, the laryngeal bed, I am trying to lateralize one vocal cord. And this I am doing by passing a proline and taking it and again from above the vocal cords. I think the video is self-explanatory. And I'm using a Dacron mesh for lateralizing the vocal cord. The reason why I want to lateralize is just to avoid another web formation. And after a period of 3 months, this mesh is removed, so that you get once again a normal, pristine vocal cord. So that's the lateralized vocal cord. Here the lateralization is anterior, please note, not posterior, as we would be doing for bilateral vector paralysis. Papilloma larynx is one of my biggest nightmares. I have a big collection of patients with papilloma larynx. And the reason why I have this is simply because doctors are very happy to refer patients with papilloma to another person. One of the commonest referrals from ENT colleagues to me is either papillomalarynx or laryngotracheal stenosis. I wish I would have more tympanoplasties referred, but this is what happens. Because nobody wants to have it, they're fed up. You've done 10 operations, 12 operations, and then eventually you say, that's it, this is about it. So these patients come and land up with us, and we have to laserize these patients. Fulguration of papilloma by a laser has the advantage that you are shooting a laser from a non-contact or near-contact mode, and you're vaporizing the tissue. So there is no tissue contamination. But does it guarantee that it will not come back? No, of course not. That it will still come back. It may come back. But your chances are much less than by physically removing these papillomas or using a diather. So a laser is a better tool. It causes less heartache for you. You can use it in the trachea. You can use it for tracheal papillomatosis. I had one patient who had almost 100 papilloma in the trachea. He was a professor of economics in college. And each time he would come, having coughed out some papillomas, we would go in and find about 30 or 40 small lesions, and we would laserize it. Eventually, after about 6 or 7 of these occasions, he has settled down. So it is a great tool for a very difficult problem. But I am very convinced that eventually the treatment of papilloma of the larynx has to be pharmacological, not surgical. Now, arytenoidectomy. Bilateral abductor palsy, again, has been a big problem for many of us. And we've tried various techniques of external arytenoidectomy, of lateralization of the vocal cords, endoscopic lateralization. Always the problem is that initially you get good results, but with time, when you lateralize, eventually this is negated and the problem goes back to square one. So here we have a KTP laser used to laserize the vocal process. Essentially, we remove the vocal process of the arytenoid and the posterior part of the membranous vocal cord. We do not, I repeat, we do not transgress the body of the arytenoid or the interarytenoid region. These are sacrosanct. And if you touch this, you end up with granulations. So therefore, it has to be very precise about what we are going to do. Most of these patients can be decannulated within the first few days. And it's a great sight for people who have had tracheostomies for ages to get it out. Now, what are the advantages? You avoid an external approach. You avoid tracheostomy. In a patient who has not had tracheostomy, you don't have to do one. It's safe and effective in establishing the airway. It's a single-step procedure. And you get a reasonably good voice, a little bit of a breathy voice, but a good voice. And if required, you can always redo it. If you can take a little less first time, assess, and then if you want to go back, you can go back and take a little more next time. It's what we call mouse nibbling of the arytenoid process. Now this is the right and that's the left vocal cord, an endoscopic view. You can see a tube. It's a different tube. It's a laser safe tube. This tube you can shoot with the laser, nothing happens. And that's the right vocal cord, the vocal process and posterior third of the right membranous cord. So I'm going to limit myself to this area, preserving the anterior 2/3 of the cord. Now this tube, I must say a few words. It is a double cuff tube. There are 2 cuffs. And it's a special laser safe tube, which will safeguard, even if your laser shoots the tube, nothing will happen. It won't catch fire. And that's one of the greatest concerns in laser surgery of the upper airway. And the 2 cuffs are inflated with methylene blue solution, not with air. So if you accidentally puncture the cuff, the methylene blue comes out. You know you've punctured the cuff. Incidentally, the methylene blue also acts as a fire extinguisher. The fluid comes and douses any chance of a flame. So here, you can see that I'm taking away more and more of the posterior third and the vocal process on the right side. You can choose either side to do the surgery. It's your choice. Usually, if there is some movement on one side, then we preserve the opposite, totally paralyzed vocal cord. We can go up to the undersurface of the cartilage if required, so that you get an adequate airway for the patient to breathe with. The other emerging indication for laser, more and more work being done, is in the field of laryngeal cancer, and particularly early malignancies, in situ lesions, dysplasias, keratosis, pre-malignant lesions, and infiltrative glottic cancer where the anterior commissure arytenoid are not involved, the cord is freely mobile. In other words, T1. The indications for laser are also the same as indications for radiotherapy. But nowadays, lasers are being used for more and more extensive disease of the larynx. The one advantage is that you use a single sitting procedure. When you use a laser for a T1 lesion, it gives exactly the same results as radiotherapy. The voice is of the same quality, the 5-year survival rate is exactly the same. The advantage is that it's a one-time procedure as compared to 30 or 40 sittings which you're going to be giving with radiation. So the advantages are obvious. And you still maintain the option that you can use radiation later if required, if there's any recurrence. And it's, as I said, the recurrence rates are similar to radiation. Now that's a verrucous carcinoma of the vocal cord. You can see it's a very exophatic lesion, although it is still a T1 lesion, and that's the left vocal cord being laserized from it. After we remove the lesion, the bed is painted with the laser. So this will destroy any viable malignant cells in that area. Now this is a more advanced lesion. It's a T2 lesion of the right vocal cord, and you can see the malignancy infiltrating into the substance of the ligament of the vocal cord. Now in this situation, a cordectomy is the obvious answer. The advantage is you can exactly remove the malignancy, the involved portion of the vocal cord, and maintain the surrounding normal healthy tissue. So you do a cordectomy, you can be very precise in your limits of excision, whereas you can save what can be saved in this patient. So that's the laser being used in a near contact mode, and you can see that straight away I'm creating a plane between the tumor there and the healthy tissue around. So that's healthy tissue and that's tumor, and I've got a plane between the two. Once you've done that, then the rest of it is child's play. You can create a beautiful plane, you can remove the tumor and preserve surrounding tissue. The other advantage of using a laser is that the laser automatically seals any lymphatic channels. So the subsequent spread of microembolism through these lymphatics is also prevented. So the advantages are quite obvious. So again, after removing the tumor, the bed is painted with a laser to vaporize any potentially viable malignant cells that you may have overlooked. So this is an unusual problem. It's a large pleomorphic adenoma of the larynx. It's been operated about 3 times, including a laryngeal fissure. And this huge benign tumor keeps recurring in this very young lady who is about 25 years old, and she's a very senior executive in one of the corporate houses, international corporate houses. She has to use her voice. So laryngectomy, even though it would be an obvious answer, is not acceptable to her. So in a situation like this, the laser becomes the only tool that is helpful to us. So here we are laserizing the benign tumor. It's attached to the right arytenoid and extending just below the right arytenoid. So I'm removing the tumor with a plane of healthy tissue around, leaving behind a plane of healthy tissue. And after removing it, of course, here the possibility is that because you're going to the arytenoid, you're working on the arytenoid, you may end up with a certain degree of dysphagia post-operative, odinophagia. So patient has to be kept on right tube feeding for a few days. And I would definitely do a tracheostomy in this patient because of the chances of post-operative edema in this patient. But it would be a temporary defunctioning tracheostomy, which could be probably decanted in a couple of weeks' time. But at least you have the option of preserving the larynx, of saving the larynx. And this is one of the greatest advantages when you are using in a situation like this. And finally, but not by any means the least of the problems, is laryngotracheal stenosis. And for years and years, we have battled with this problem. Endolaserization, or laserization with an endoscopic approach, with either permanent or temporary stenting, seems to be today the gold standard of treatment. It has several advantages. There's no external incision. It's a single-stage procedure, safe and reliable. It does not compromise on subsequent anesthetic procedures. This patient can, once cured, go on for subsequent surgery if required. And you have a bloodless field, and it can be, the laser is passed through different modes of application, like a bronchoscope or through a microscope and so on. Now that's a permanent tracheal stent. It's made from a material called nitinon, which is a nickel titanium alloy. It's a byproduct of NASA technology. This is the same material which is used for coronary stents when you're doing angioplasties. The advantage of this is that this material has a memory. So when you heat up a material and make it into a shape of a cylinder, you can cool it and then you can thread it on a delivery stick and make it into a very compact shape. When you release it into the body temperature again heats it up and it once again gets its original shape. So in other words, it has a memory. And this has been put to good use both for the esophagus and for the trachea as well as for the coronary arteries. The procedure is simple. Anesthesia is challenging. You want to have an intravenous propofol supplemented with topical anesthetic. Patients who don't have a previous tracheostomy are managed by spontaneous ventilation. They don't need a tracheostomy for the procedure, but who have a tracheostomy are ventilated through a tracheostomy. The stenotic segment is laserized, and it takes, you laserize till you get at least about 75% of the airway. The laser can cut not only cartilage but also bone. All you have to do is to change the wattage. And when you do that, you can excise a stenosis, whether it is tracheal or whether it is laryngeal or even if it is fully calcified. Now, this is an example of a patient. That's a bronchoscope going. That's a subglottis region. You can see a small little pinhole. That's all the airway. This patient has got absolutely narrow stenosis. He's got no chance. He's got a tracheostomy, obviously, with which he's carrying on. Now, this is a laryngoscope. You can all see a suspension laryngoscope, and I am laserizing the stenosis. The laryngoscope is passed between the vocal cords to throw open the vocal cords so that you reach the subglottis. And you can use the laser to laserize the segment. Doesn't matter how long the segment, whether it's an annular stenosis, a cylindrical stenosis, 2 centimeters, 3 centimeters. Now that's the stent being deployed. You can see that it's in position there across the stenosis, and then you release it and you take out this, and that's it. That's the procedure. So you have a permanent stent in the trachea. As a matter of policy, now that's the stent that you can see with all the mesh. It looks like a mesh. It looks like a Spider-Man movie. The reason why there's a mesh is between the meshes the mucociliary epithelium grows, and you have a chance of maintaining the ciliary clearance even when the stent is in place. So it is bio-integrated into the wall of the trachea. Now this stent cannot be used in children because we still don't know what it does to a growing trachea. But it can be used in adults. As a matter of policy, I use a stent, a permanent stent, when the stenosis is annular, when it's not too long. When I have a very long stenosis, I prefer a temporary stent like a Montgomery T-tube, which I remove after a year. If there is still a small stenosis, I then use a permanent stent. So permanent stents I reserve for short segment stenosis because you don't have too much of loss of respiratory epithelium. So these are some of the examples of how a laser could help you with some of the very difficult problems in the airway. It makes difficult problems easy to manage. And as I told you at the beginning of the lecture, as a surgeon, I sincerely feel that I have to make my own life easy because I can't see anyone else making it easy for me. Thank you very much indeed.
Thank you, Dr. Mohan. Other question I asked him, that before purchasing or trying to do laser, the first thing you should do to get a training. And you know, Dr. Commissioner, he has kindly consented that anybody who wish to have training in his clinic is always ready. And I think we should applaud him for that. He asked me that beforehand we should write to him, and he said, whenever I am in Chennai, I am available 7 days a week. So if anybody of our enthusiastic colleagues wants to have training in laser surgery, he is free to write a letter to our esteemed guest speaker, Dr. Mohan Commissioner. Thank you, Dr. Commissioner.
Thank you, sir.
Thank you.
Step the trachea more concentrated.
Yes, that's an extremely sensible and logical question. What madam is asking is, how does the stent stay in place? Why does it not migrate? In fact, the reason why it stays in place is simply because you have to assess visually the diameter of the stenosis and get a stent which is just right, little bigger than the diameter, so it will grip the wall. It's an elastic, spring-like material, so therefore it will hold on and hug the wall and it will not migrate. If you use a smaller stent than we require, then this risk is there that it may migrate. Although within 2-3 days it will get held by the epithelium. But when you're deploying it, you have to have an excellent assessment. There are also tools for assessing the diameter, but visually you can assess and see how much diameter you have and how much you need. There are stents of different sizes available, so that you can choose the stent that you want and use it.
Hello. We have been directed by the organizing committee to maintain discipline and
Thank you, Dr. Saad, and thank you. Thank you, Dr. Ibuya.
Auditor, as a surgeon, I am really very grateful for having this opportunity and getting this invitation from the organizing committee, NEBAOI 2004. When I got the invitation, I delighted to have this, and immediately I phoned and informed them about my availability to speak before you during this memorable conference of yours. As you know, some of you at least, I am engaged in oncology surgery. Mostly nowadays I do micro-ear surgeries. And I had the opportunity to conduct workshop once in Silchar few years back, and only in the last May 2004 I conducted micro-ear surgery at Nebaoicon hospital. Already you have heard about that. So it was a nice time to have such a workshop conducting at Silchar as well as at Guwahati. And moreover, I am so happy that repeatedly getting invitation to come over here in this northeastern region. And most of you do not know, I delivered Professor Siddhar's oration at Tejpur in the year 1995, long back. So I am very happy to come over here repeatedly and to share with you my experiences and also to learn from you. Before I start my talk on the subject, which is not new to many of you, because during the workshop I demonstrated this operation in both the places that I mentioned. And I had two brain children. One was neostepidotomy, about which I thought for the first time, perhaps, in India. And that neostepidotomy has come in the literature that has been published in IGLO. And some of you, I think, you know the term, what is neostepidotomy. And I delivered the lecture of Dr. Siddhar's oration on neostepidotomy long back in 1995. Now, my second brainchild is another subject, is three-flap tympanoplasty. And that too, probably some of you are hearing for the first time. And what is three-flap tympanoplasty? On going to the literature, I have seen none in this world literature have reported or done this operation before. And this three-flap tympanoplasty is very, very simple operation. And a beginner also can finish the operation within a very short time. And success rate is more than 94%, 95%. So about that subject I will talk to you. Three-flap tympanoplasty as I do it. Now the thing is, how this operation had come to my mind. In my earlier days, I started doing micro-ear surgery in 1964. when probably some of you seniors remember that Michel Portman came to Calcutta to demonstrate his surgery, and I assisted him in 1964 in my institution. At that time I was in Calcutta National Medical College, Kolkata now. So what happened while doing tympanoplasties in cases with subtotal perforation, in cases where there is an anterior overhang? Many of you have got that experience, how difficult it is to put the graft. And some of these patients used to have perforation in the anterior part of the graft, leaving an unsuccessful rate of surgery like tympanoplasty. Then I started thinking how I should come over about this problem. And you have got literature nowadays how it is to come over. In a book like Mawson's latest edition, Arnold's, he is putting the anterior graft, anterior portion of the temporalis fascia graft, making a perforation in the anterior wall, drawing the graft through that perforation in the anterior wall so that it doesn't produce perforation in the later time. That you have come to know in the literature only a few years back, 3, 4 years, 5 years back. But I was thinking about this about 20 years back. And having this idea in my mind, how I will come over the failure of tympanoplasties while we do in subtotal perforations or in cases where there is anterior overhang, where it becomes difficult to put the graft in the anterior part. So with this prelude, I want to start my speech. Next slide, please. 3-flap tympanoplasty as I do it. And I don't know whether any of you here doing it or not. I don't think that you are doing it. This has not come in the literature as yet, but this has been accepted for publication in our Indian Journal of Otolaryngology. Probably this article will be coming this month, that is September issue of IGLO. So you may go through that article. Next. As you know, I work nowadays after my retirement from the government service in the year 1994 December at the age of 60. I am approaching 71 now, running 70. So I am also like our senior elder Dada, Dr. Sidas. I know Dr. Sidas, Professor Sidas, since 1963-64. Probably at that time he was at Lucknow Medical College. I met him there when he was doing MS. I was just a house surgeon at that time. So, now I am working at R.K. Mission Seva Pratishthan, Vivekananda Institute of Medical Sciences, Kolkata. I was head of the department there. Now, as you know, according to university rules, after 65 years of age, you cannot remain as professor head. So, I am working there now as senior consultant. Next slide, please. This is my institution, Ramakrishna Mission Seva Pratishthan, Vivekananda Institute of Medical Sciences. Next. As I was telling, the pioneers in otologic surgery, all of you know about Zollner, Woolstein, Shambo. Recently, in 1998, while I was going through the literatures to write this article, Al-Shaikh, 1998, he reported to overcome this type of complications to make two flaps, that is anterior and posterior flap. Next, Lardman. Already I told about this Lardman's book. Probably I quoted the wrong name. Please excuse me for that. Lardman in 1998 again. This anterior tunnel he described just to overcome the complication in this type of cases to have perforation in the anterior part. Now another surgeon, Cartouche, in 2002, he mentioned about the over-under tympanoplasty. And he also mentioned that the flaps that you make, 2 flaps or 3 flaps, all those flaps are vascular stream or QT stream because the graft gets nutrition through those flaps, and graft, that is temporalis fascia graft, becomes stable by putting those flaps. Next please. Now what I do as a pre-medication, I think all of you do this, all these cases I do under local anesthesia. And as I pre-medicate to my patients, which is very, very important, if pre-medication is not good, whatever amount of local anesthetics that you inject during the surgery, you will not get a quiet patient. So pre-medication is very important, and I give 1 tablet of diazepam in the night before operation, and another tablet of 5 mg diazepam 2 hours before the operation, and injection of pethidine or photoin, because pethidine I am not using nowadays quite commonly because pethidine has got many disadvantages. Though it has got many advantages, the disadvantages are you will not get a good pethidine. All are spurious, just like simple water in the ampule. And I have seen people in the operation theatre, even the doctors, anesthetists, they steal this pethidine and they take it in the OT. So you will not get pethidine unless you are very careful. That's why I shift on to 40. And I give 1 ampule of 40 and 25 mg of phenergan intramuscularly, about 45 minutes to 1 hour before surgery. And with this, I did operation here in Nemcare Hospital also. And probably they have also noticed that how quietly patient remain just like general anesthetics. Next slide please. Anesthesia, this is also important. Because as you know, probably some of you know that I do all these operations under modified endaural incision. I will show you later on. And modified endaural incision means Lempert's incision has got 2 wings, I think you know. One is the vertical, the other is horizontal. Here, in majority of the cases, I use only the vertical one. And idea of that incision is to explore or make the field of operation wider so that you can get a good view of the field of operation, field of surgery. And you probably know that many people, they do, yesterday also we saw that they are doing tympanoplasties in the post-oral incision, which I do not prefer. So, for preventing too much of bleeding by giving endaural incision, I use about 50% dilution of adrenaline with 2% xylocaine. And that is done by adding half ampule of 1 in 1000 adrenaline with 30 ml of 2% xylocaine with 1 in 2 lakh adrenaline. So that comes about not exactly 50% of adrenaline in 2% gyrocane. So that gives practically a blanched field of area during the surgery if you give incision. Next please. This is the modified endoluminal incision that I am showing you. Next. You click it, you get you just click, you get the movie. Yeah, now you see the incision. These I give in the incisura terminalis, as you know, between the tragus and the helix. And it goes parallel to the helix and very close to it. And you see the perforation through that, there is a big perforation, large central perforation. This is to show you 3 flaps, how I make it. This is just a figure drawn. And say this is in the right here. I give incision, one at 11 o'clock, the other is 1 o'clock, making a vascular streak with the superior flap, and the other one at 6 o'clock. So these 3 incisions are given, making 3 flaps, superior, anterior, and posterior flaps. Previously, I used to do 2 flap techniques in these type of cases, raising that superior flap and raising another flap from 1 o'clock to 11 o'clock. So in majority of the cases where there is anterior overhang, the visualization becomes very poor because this inferior flap becomes very large, the field of operation becomes narrow. So I decided, why don't we give a second incision or third incision at 6 o'clock, making anterior flap, posterior flap. And as you have seen, Al-Sheikh also has thought of, and he had given anterior flap, posterior flap technique. Though he has not mentioned about the superior flap, because with the posterior flap, he raises the superior flap along with, thereby making anterior flap and the posterior flap. That is by Cactus. Al-Sheikh, sorry. So next please. This is to show, this is the figure taken from Shambo. All of you are aware of this figure. Shambo used to remove the cuticular epithelium from the pars flaccida as well as from the long process, endolomalius. But I do not do that. What I do, can I have the pointer please? I raise the flap, superior flap, from the handlomalius. I raise the flap from here, handlomalius. Don't remove this cuticular epithelium. I'm making the superior flap from here. This is by Shambo. This is superior flap or vascular streak or cuticular streak. So this is to show that I do not follow this. Next. What I do, I raise the cuticular epithelium from near the ambo. Raise it, and go along like this. This is just a drawing. So this superior flap has become very long. And after putting the graft, when you replace it, that comes up to very close to the handlomalius there. Ambo. Comes very close to ambo. Then after giving a 6 o'clock position incision, raise the anterior flap, raise the posterior flap. And after that you clean if there is any pathology here. Usually most of the cases do not have any pathology. If there is any pathology like osteotoma or conventional tissue, I do not go for this procedure. Next please. So click it again, it is moving. Now you see, after modified endoluminal incision, the anterior incision is given at about say 11 o'clock position. This is in the left here. And the posterior incision is given here at about 1 o'clock position. Then raise this flag from, here is the tip of the malleus, that is Ambo. And from there onward, I go on elevating the flap, as you see here, very big flap, superior flap, goes up like this. You see the handle of malleus, which is clean now, here, without having any mucosa, without having any fibrous layer, without having any skin. Now the third incision is taken here at 6 o'clock position. Now the anterior flap is elevating with the help of a circular knife. And here you should remember that most of the time, if there is an anterior overhang, we can't see the rim of the perforation. So what happens after this incision, you elevate the flap, and so that the rim comes very close to your eyes and you can clean it. You can remove the rim of the perforation in the anterior part, even if you cannot do it earlier. Now the posterior flap is elevated. Here, you can see the anterior flap. If there is any rim remains here, you can remove because it comes so close to your vision. And here also you can treat it. Clean the rim of the perforation, now you see. So all the three flaps have been elevated, superior flap, anterior flap, and posterior flap. That is why I call it three-flap tympanoplasty. Next. Now, few points regarding gel form. I am so happy that for the first time, one of my Indian colleagues, Dr. Mohan Commissioner, you have seen his operation yesterday, I also saw. Before putting the graft, in a case he was doing, he did not put any gel form in the middle layer. And that is, I was trying to hammer for many years, but people, they are so much habituated in putting gel form pieces into the middle layer, according to Shambo's teaching or some other teachings. I do not know, is there any advantage by putting gel form pieces into the middle layer or not. And I don't know, Dr. Mohan Kameshwaran will be able to answer. His opinion also, he says, I was asking him after the completion of the operation, yeah, I noticed that you have not put gel foam pieces in the middle layer, because I never put it. But I never asked him where from he got this idea. So I will ask him afterwards. So, definitely not from me, though he is very junior to me because it was not published. So, these gel foam pieces in the middle layer, before putting this graft, this was the figure taken from Shambo's book. I never use it. Next please. So without putting the gel foam pieces into the middle layer, I have put the graft. You see the graft. And after that, these flaps, the superior flap and the anterior flap and posterior flap are replaced over the graft. Next please. Tip lip is removed, yes. Now you see, after elevating the flaps, three flaps, I put the graft in the middle layer. Rather, I put the graft all around, over the bone. It lies on the bony extraordinary canal. You can see the anterior flap. The graft is going there in the anterior wall of the bony canal. Anteriorly it was put, inferiorly it was put, superiorly you will have to push it, anteriorly, anterosuperiorly. Then onto the posterior bony metal wall, this will be raised, you see. So spreading of the graft all over is very, very important. You must spread it nicely. And have not put any gel foam pieces in the middle here. And this is to show how it blows up. I think in the morning you are having puris, it's just like puris, the graft blows up. And if you put gel foam pieces, air cannot come in, though it is told that you should not block the eustachian tube opening. But it is very difficult. If you put the gel foam pieces and put medicine, it swells up and blocks everything. So you replace the flaps. Anterior flap has already been replaced. Now superior flap will be replacing. This is the graft. And this is the superior flap. Very large flap, you see. And you can make out the difference between the color of the graft and the flap. This is a rough graft and the flap is shiny here. The skin is there. Practically, the superior flap has come up to the level of the annulum malleus, tip of the annulum malleus or arm. Now the posterior flap is replacing. You see, so nice flaps on the, and it is so simple. And now you see the graft, which has blown up, indicating that the eustachian tube is patent. Number one, if you put gel foam into the middle layer, you can't get that idea. Secondly, you see the graft has blown up. Next please. Then secondly, you can make out whether there is a leak between the graft and the flap is present or not. It is not present. Had it been there, the graft will never blown up. This is another point, another figure from Chambo. I am differing with Chambo in the form that these gel foam pieces were put over the graft. As you have seen my graft and put the gel foam pieces. These are the foam gel foam pieces. These are the gel foam pieces soaked with eardrop, antibiotic eardrop. And if you soak it before putting it, it doesn't remain like this as you see here, like balls. It becomes very soft and jelly-like. Naturally, it is difficult to put in different places, in different nooks and corners. So that's why I do not use it. That's why I am showing you this figure. Next, please. This is my techniques. You see, after putting this graft, replacing these flaps, 3 flaps, click it, please. Gel foam pieces. These are dry gel foam pieces, and you will have to push it along with the wall, stretching the flaps, go down up to the annulus tympanicus. As you know, it is subtotal perforation. And if you do not go up to the level of the annulus or up to the end of the flaps, it will not remain in place. It will be coming more laterally. So lateralization of the graft will be there. So, but if you use dry gel foam, and push it down, up to the level of the annulus, up to the level of annulum minors. The lateralization of the graft also becomes very minimal. Not that it doesn't occur. In very few percentage of patients it can occur, but it is very, very rare. Then after that, I close this incision with 6 stitches. Nowadays, I am preferring, Bikri, 20 Bikri, and if interrupted sutures and inverted sutures, so that it doesn't require removal afterwards. So Bikri sutures I am applying nowadays. So this is the silk thread stitch you are seeing. So I think I could impress upon you regarding the feasibility, utility of having three-flaps technique of tympanoplasty in some percentage of patients where you cannot see the anterior rim of the perforation. If it is small perforation or posterior perforation having good anterior rim, this technique is not practicable. I do not do that. So this is what three-flap tympanoplasty. So before I end up, I had brought CDs having 4 operations like stepidotomy, neostepidotomy, canal wall mastectomy tympanoplasty with ossiculoplasty, and also three-flap tympanoplasty in a different case. So those CDs I have brought to present to the Northeast Branch AOI from my part. I thought it is the right forum to present my CDs to this association. So may I request the representative, the secretary and president of NABAOI, please come forward and accept my presentation.
The main objective is to preserve the nerve if possible. That it is seen many a time, it has not been possible to preserve the nerve because the tumor is arising or having attached very broadly to the nerve. One can see we are trying to take out a secondary attachment, slowly with a seizure. You can see the different area. Again, the 6 nerves which have been dissected. The steel very broad base. This looks like a ganglion. Maybe going down, dissecting the lower part. At this point of time, we are using the bipolar cautery. Keeping the cautery away from the trunk, not front. You can see it is almost strained. And again, you want to see the biggest nerve here. You can see the carotid pons, carotid vapors post anteriorly. Here, that's the biggest nerve lying between the carotid and the intranascular vein. And it's the both the hypoglossal nerve. And it has to be from the sympathetic trunk only. It is lying deeper and medial to that. When dissection has been carried out, and you could find that there is attachment to the side of the nerve, and you could clamp at the same time to preserve the nerve. But we cannot always, in all the case of parapharyngeal tumor, it is not possible to preserve the nerve.
Go to the next slide, please. Now, as we have seen that, the cervical approach, what I have shown you just now, but sometimes in certain occasions, we are very fortunate that the tumor was shown you that only strictly localized in the parapharyngeal space below the skull base. But sometimes the stem tumor may go up to the skull base. It's very, very difficult to deliver the tumor from the below. In that case, you may have to do the mandibulotomy. But mind it, mandibulotomy is not always necessary to perform to deliver the parapharyngeal tumor, nor mandibulotomy or without mandibulotomy makes the surgeon great. What I mean to say, when it's necessary, you may have to do the mandibulotomy. If not, it's not necessary. Then you want to do the mandibulotomy. What type of mandibulotomy one should do? There is big controversy about the mandibulotomy. There is a lateral, stair-step one, angular one, and paramedian one. The paramedian one we have done, but we found out a lot of problems. Paramedian is somewhere here, and your tumor is here. When you do the mandibulotomy, you have to retract quite a lot of soft tissue from here to here. So in my mind, this may not be a very ideal situation. In a sense, patient who got undergo paramedian and undergone all the retraction post-operatively will come with a lot of edema because it's subsides. It may not be a big deal. Second, an angular one is the one is very near. It's here and you stay there, get the parapharyngeal space. But again, the reconstructed curve in the angular one is no better than the paramedian or the lateral stair. So it's up to you, but you have to look at the statistics. A maximum number I have done paramedian and angular. Now come to the conclusion that probably stair-step one and angular is better than a paramedian one. Next slide. This is another patient from the tumor. You can see the carotid vapors. Next slide, please. This another patient is showing that all vapors. This is probably the common facial vein, internascular vein, and your carotids are being pushed anteriorly. Next slide. This another patient. Next slide. Next slide, please. This is after excision. See how close the tumor lies to all to the great vessel. One has to be very, very careful. More than that, you have to identify in its and every structure if you really want to do a successful excision of the parapharyngeal mass. Next slide. This is what the stair I talked about, the stair step one. It gives a good cosmetic value, that can make this one goes around and reconstruct. The post-operative morbidity is very, very less. Next slide. Sometimes I tell you that this one called Wheeler's approach, but staying start with the transcervical, transmandibular, transpalatal approach. It may be good for the parapharyngeal tumor involved in the skull base. And the reason why it is good, it's a very wide incision and wide exposure, you can see the structures better. But again, the incision is too big, post-operative morbidity is much more than the other approach. Next slide. Is another one. Next slide. What is the complication you find? Complication of aspiration, hoarseness, dysphagia, Horner syndrome, shoulder drop. Maybe the lower cranial nerve, that is the most common cause. It may be injured accidentally, or you may have to excite, because if you splayed over the tumor, you may have to cut a nerve. But these complications were a problem in earlier days. Now, with the invention of your phonosurgery and laser myotomy, this can be very, very easily tackled. Next slide. In conclusion, ideal surgical approach should have less tissue and nerve manipulation. As I told you, like pyramidal mandibulotomy gives a lot of tissue manipulation. The post-operative patient will have a duration of morbidity will be high. Cervical approach I found to be better because of its flexibility. What do you mean by flexibility? I can transfer to the transpalatal, you can transmandibular, or it may come down. So it is very, very versatile approach, and I feel this is one of the best approach for excising the parapharyngeal tumor without doubt pelvis extension. Cervical parotid approach appropriate for deep flow parotid tumor. Mandibulotomy, as I told you, is optional. If necessary, you do it. Don't try to come back. There are some surgeons, and there are many of the conferences. The few of the surgeons came and I don't do mandibulotomy for parapharyngeal tumor. What does it mean? Are we better than the others? To my mind, no. If necessary, we'll do it. If not, we don't do it. By not doing a mandibulotomy for a parapharyngeal tumor extending to the skull base, which is a foolishness. So in other words, I don't give importance to the quality of surgeon, whether he does mandibulotomy or not, and I feel one should not give. Appendix and ultrasound guided is very, very cost-effective investigations in expert hand. Next slide. Thank you very much for giving me the opportunity once again, and I'm very proud to be here. I'm very proud to be your ovation. Thank you once again.
And on behalf of the organizing committee, we'd like to felicitate Professor Hazarika. Now I'd like to request Dr. Yuti Buyar.
Next slide. Introduction. The nasal endoscopy has evolutionized the treatment of nasal and parietal sinus diseases. The Massachusetts work on precautionary transport mechanisms in the PNS laid the foundation for the development of face. The advantages are radical procedure can be avoided and invasive diseases limited procedure is sufficient. The horizon of the nasal surgery has gone far beyond face and now includes various orbital and anterior skull-based procedures. Next slide. Aim and objective of our study was to broaden our understanding of normal anatomy and the variations of the lateral nasal wall, to explore the intricate anatomy of the lateral nasal wall in cadaver and application of the knowledge in living. Next please. The method study was conducted in the Department of Sensory Medical College and Hospital. Here, life surgery is going on here. Cadaver dissection look, the cadaver is over here. Next slide. Metal few endoscopes and few instruments are shown over here. Next slide. Cadaver specimens were used, which are available in the department, and patients with sinonasal pathology were selected for the study. Next slide. Diagnostic nasal endoscopy is done in 3 passes. In the first pass, the endoscope is passed along the floor of the nose between the inferior turbinate and the septum to the posterior nasopharynx and to see the eustachian tube opening and the tubal cushion. Eustachian tube opening and tubal cushion over here, and beyond that, the fossa was a molar. Next slide, please. tilting the endoscope, you can see the posterior end of the nasal septum and the opposite institutive opening and institutive depression, and the rotation of the endoscope in 360 degree, you can see the muscular process of uvula and the upper surface of the soft palate, and you can, withdrawing the endoscope through the inferior meatus, you can see the opening of the nasolacrimal duct and over Hester's valve, you can see over here, next slide please. The second pass is to see pass between the middle terminal and the septum, and you will see the sphenoid recess and superior meatus. Next slide please. The third pass is the most important pass. It is to see the middle meatus over here, the ancillary process and the bulla equinalis, and the opening of the some anterior equinal cells over here. It will be sometimes difficult to pass the endoscope anteriorly. Then there are three options. You may pass the endoscope through a trocar, and you may medialize the middle terminate. Then third, you can pass the endoscope from posterior to anterior and examining the from posterior to anterior side. Next slide please. So osteovenous complex. Osteovenous complex can be divided into osteovenous complex anterior and posterior. The anterior comprises of the ethmoidal infundibulum, the drainage of the maxillary sinus, and the frontal recess, the drainage of the frontal sinus, and posterior, it is sphenoid recess, the opening of the sphenoid sinus, medial to the superior terminate, and superior meatus, the opening of the posterior ethmoidal cells are shown over here. And osteovenous complex can be defined as a single common pathway for the drainage of the maxillary and frontal and anterior ethmoidal cells. The next slide please. The middle terminate, here two specimens. The middle terminate, here there is a cleft, and here not. And here middle terminate is not a reflected back. You can see the ancillary process for accessory ostium, the bulla equinalis, and opening of the some anterior ethmoidal cells. You can see the middle terminate and ancillary process. And the middle terminate has got three attachments. The anterior attachment is vertical, the middle attachment is oblique, and posterior attachment is horizontal. So next slide please. The basal lamella, the middle part of the middle terminate is called the basal lamella. Here you can see the basal lamella. It is attached to the lamina papillacea. It is most important. It is the third lamella, and it is most important for stability of the middle terminate. And if to enter the posterior point, you have to perforate here the ground lamella at the junction of the vertical and horizontal part, inferior medially. Next slide please. And the variation of middle terminate we conta bulosa, that is pneumatized middle terminate here, it may give pressure to the ethmoidal infundibulum, which may hinder the drainage of the maxillary sinus and the paradoxical middle terminate. Next slide please. The ancillary process is the first one. In these two specimens, you can see here the ancillary process is thick a bit, and here it is the ancillary process is slightly thin and laterally curled up. And you can see the accessory ostium over here also. And the superior attachment is important. In that sense, it determines the drainage of the frontal recess. It may go up to the ethmoidal roof, or it may turn medially to attach to the middle terminal, or it may go laterally in most of the cases, 80% cases, then forms the recessus terminalis. Then it forms a blind sac. Then next slide please. Infundibulotomy is the first step of the operation. The same process you can palpate it posteriorly and give incision over here. Black correlation is shown over here. Next slide please. And here infundibulotomy, the lower end is removed here and upper end is removed here. In the left side, the Blackstreet forceps, rotation of the Blackstreet forceps should be the anti-clockwise direction in the lower portion. In the upper portion, the Blackstreet forceps should be rotated lateral wall, so that it is not above the mucous membrane from the middle terminate. Next slide please. Ostium of the maxillary sinus, limited nasal ostium. Here it is nasal ostium is shown, here the accessory ostium is shown. It is just after ancyllectomy. Normally the nasal ostium is not seen by endoscopy, and if we see a ostium, then it is usually the accessory ostium. The nasal ostium makes a previous one. Nasal ostium makes a 15 to 20 degree to the horizontal, and the accessory ostium usually in the vertical plane, sagittal plane. Next slide please. The accessory ostium shown over here in the endoscopy. Here it is usually round and it may be multiple. And if the two ostia passes, then you have to join the two ostia to prevent the circular megaly sinus. Next slide, please. The middle meatal endoscopy. Here, middle endoscopy is done here. Here, the backward cutting forceps is used to dilate the middle ostium. The anterior dilatation may cause injury to the nasolateral duct, and posterior it may injure the sphenopalatine artery. Next slide, please. The nasal fontanelles. These are the areas devoid of bone. It is divided by the anterior posterior by the uncinate process. And surgical importance is that the nasal ostium can be widened at the expense of it, or during endoscopy you may see some congestion over here, which indicates some pathology in the maxillary sinus. Next slide, please. Hiatus seminaris superior and inferior, that is the inferior hiatus seminaris, is the crescent space between the posterior border of the uncinate process and anterior border of the ethmoidal bulla. And the ethmoidal infundibulum drains through this hiatus to the middle meatus. And sinus superior may be entered for this. And hiatus seminaris superior is a crescent space between the ethmoidal bulla and the miditerminal. Here miditerminal is reflected back. Through the hiatus seminaris superior, you can enter to the suprabular or infrabular recess. Next slide, please. Agarvale cells. These are the prominence, just anterior to the middle terminal, and they may be pneumatized from the frontal recesses, and they may enlarge posteriorly, which blocks the frontal recess. And usually they are seen on the coronal section. Next slide, please. Ethmoidal infundibulum. Here the band ball probe is inserted in the ethmoidal infundibulum with the uncinate process, which forms the medial anteromedial boundary, and it is a three-dimensional space, V-shaped space, and it drains through the hiatus seminaris to the middle meatus. And there are 4 endoscopic clues to see any pathology in the infundibulum. Number 1, any pathologic changes. Number 2, any pathologic discharge. Number 3, any anatomical variations which give pressure over here and which causes blockage of the ethmoidal infundibulum. And number 4, there will be some mucosal changes or pathological changes. Next slide, please. Ethmoidal bulla. Ethmoidal bulla is the second lamella. It is seen nicely after the uncinectomy, and here you can see the 2 bulla. They are a bit different. Sometimes the bulla may be ridge-like, and it is called porus lateralis. And ethmoidal bulla, you have to enter through the anterior inferior-medially, keeping the lateral wall intact, and the direction of the instrument should be parallel to the bulla. Next slide, please. Sinus lateralis. Here it is bounded anteriorly by, this is the sinus lateralis, anteriorly bounded by the posterior border of the bulla ethmoidalis and posteriorly by the basal lamella. This sinus lateralis may be small or it may be large. If it is small, then there will be some such of entry to the posterior ethmoid, and if it is large, then it may bulge through to the posterior ethmoid. And so next slide, please. Anterior ethmoid. There is a basal lamella which divides the anterior ethmoid and posterior ethmoid. Next slide. The anterior ethmoidectomy. If the bulla is open anterior inferior-medially, at first the lumen is created, then it is removed. Here the bulla is completely removed. Here it is shown in the specimen. Next slide. Okay, anterior ethmoidectomy is going on in the line present. It is shown over here. Next slide. Lamina papyrus, after removal of the bulla, the lamina papyrus is shown over here, papyrus. And next slide. And the posterior ethmoid, probe is passed through it. Here, next slide. And the posterior ethmoidectomy, the direction of the forceps should be in the anterior inferior-medially. You can see over here, after posterior ethmoidectomy, there is a reddish color over here. It is the posterior ethmoidal artery, which lies few millimeter anterior to the anterior surface of the sphenoidal wall, anterior sphenoidal wall. Next slide. Haller cells. These are the cells which are found in the floor of the orbit and the roof of the maxillary sinus. This may give pressure to the infundibulum from posterior side, which may block the infundibulum or drainage, which may cause persistence of pathology. And next slide. Anterior ethmoidal artery. Here we have dissected the anterior ethmoidal artery. The branch of the ophthalmic artery of the internal carotid artery. It lies 1 to 2 millimeter posterior to the superior margin of the ethmoidal bulla. Here it is shown. Next slide. Spinal sinus. Here you can see the ostium nicely over here. So it is about 8 millimeter lower from the piriform plate. And here you can see the spinal sinus. There will be pneumatization different types, cellular, precellular, concal, and in this case you can see some cells beyond the spinal sinus, which are the Onodi cells. The Onodi cells are found about 11% of cases, and surgical importance is that if somebody may enter the Onodi cell to the anterior skull base, taking it to be a spinal sinus. Next slide please. Spinal sinus, that is the lateral wall. Here you can see the optic nerve posterior superiorly, and here one important structure, there is a lumen, it is the internal carotid artery posterior inferiorly. Next slide. Spinalotomy, you have to measure first the anterior wall. Here in the specimen it is shown, it is about 5 to 6 centimeter from the anterior nasal spine at an angle of 30 degrees to the horizontal, and 1 to 1.5 centimeter from the posterior margin, superior margin of the posterior corner. Here the spinalotomy is done over here. If you go more laterally, you may injure the optic nerve over here, and after spinalotomy you can see here the optic nerve and the internal carotid artery. Next slide please. Spinal hemolysis. Here the probe is passed from the spinal side ostium, and it is medial to the superior turbinate. Next slide please. The superior meatus, the superior meatus is cut and it is reflected. You can see the opening of the posterior epithelial air cells. Next slide please. Frontalysis. Frontalysis. Here the probe is passed from the frontal sinus to the frontal sinus, and it comes out here, tip comes out just medial to the uncinate process. The uncinate process determines the drainage of the frontal recess. So if uncinate process turns to the lateral and it attaches to the lamina papiacea, and in case of uncinate process is turned medially, and it is then goes up to the skull base. Then in that cases the frontal sinus drains to the epithelial infundibulum, and there may be persistence of pathology. Next slide please. The frontalysis surgery is going on. Next slide. The lacrimal and nowadays ENT surgeons are performing endoscopy this year most commonly. And so here we have done the coronal section, here lacrimal section, here incision is going over here, and the bone is drilled out over here, and the medial wall of the lacrimal gland is shown, and the cut over is passed through the nasolacrimal duct. Next slide. Now conclusion. As a beginner, Gettimer dissection provides us advantages such as identification of anatomical landmarks, the selection of instruments, and art of their handling, the overcoming disorientation factor, etc. So this will widen our horizon of knowledge, and application of it will become easier in living person, which is a prerequisite for endoscopic sinus surgery. Next slide. Thank you.
Thank you, Dr. Mehdi, for his excellent work.
And I'd like to request Dr. Mehdi.
Across a patient with vertigo, we find that he usually carries with him a huge thick file, and he has been kicked around like a football from consultant to consultant. Very often you have seen neurologist, neurological examination, normal, impression, labyrinthine vertigo, and refer ENT. Or you have the ENT surgeon trying to tell the patient, look, I think your ears are normal, why don't you go to the orthopedic? And he says, but I've already gone to the orthopedic, and he said, everybody beyond 45 years of has spondylosis, so go and tell your ENT surgeon this is nothing orthopedic. And usually tends to listen to the orthopedic surgeon, is usually built a little bigger. We feel that the maintenance of balance and balance disorders is a rather complex process, where there is an interaction between a lot of different parts of the body, different systems involved. And I think one other person which we are missing today on the panel is perhaps a psychiatrist, because very often there are a lot of psychological implications of the disease. Anyway, we'll start off and we'll try to keep this panel as clinical as possible. As far as I am concerned, if towards the end, as I will talk to you in my lecture tomorrow, if I get a patient of vertigo, especially towards the end of my consultation, my reaction is rather negative. I say, oh God, not vertigo, I would rather have a patient with central perforation, see him and send him off. Now, I just want to ask the panelists, and I will ask both the ENT and non-ENT people, that if in your practice, Dr. Roy Chaudhary, when a patient of vertigo comes to you, is it the kind of patient where you say, okay, this is the kind of patient I want, or, oh no, I don't want this patient, and I want you to tell us, why do you have this reaction?
If the patient with severe vertigo comes, I don't think awkward. I accept it. I receive them and I see and examine and advise accordingly.
So you're quite happy, you're not bothered by that? Only thing is, usually the patient coming to you won't be severe vertigo. He's seen by the general practitioner, and once his vertigo is gone, then he comes to you, 2 weeks ago I got an attack, and then he comes and sits in front of you. So you are quite happy to have a patient with vertigo because you can finish with him quickly, or I said I wanted the reasons why you like or don't like to have such a patient.
No question of disliking a patient.
Okay. Mohan, what would you say?
I think you're going to have the first disagreement because, as you said, at the end of the clinic, when you see a patient with vertigo walking in fact, if he's walking in, it's not so bad. It's much worse if they come in a wheelchair. And your heart sinks. I certainly feel, because to examine this patient, to do justice, and do a proper evaluation is going to take, in my opinion, not less than 15-20 minutes. The quickest of examinations. And it's the start of a long process. So it can be quite frustrating at the end of a clinic. But that's not to say that we don't want to see them. Often you have to see them, because these are genuinely distressed patients and they need your help. But it certainly makes you feel a little exhausted at the end of it.
Because you can give him immediate relief. While on the contrary, you feel that these are people seeking total instant relief and that will go. Now, I would put this question to our orthopedic colleague, that what is your reaction when some ENT guy like me says, no, this may be cervical spondylosis, go to the orthopedic. What is your reaction to this kind of patient coming?
Basically, when a patient with illness or weakness comes to me, I don't feel very happy because it's not a pleasant sensation to the patient. For some patient with a past history of similar headaches, the decadent history of spondylitis with illness, having a second or third episode, I think who doesn't have any other problem in ENT related, operating related or things like that, I take them a little easy, and then I think that they are basically belong to this group of patients. Cervical spondylitis is called the predominant. The rest of the patient, well, like to have one investigation for the company.
Do you then feel that cervical spondylosis definitely has a role to play in patients complaining? I mean, in a certain group of patients, that cervical spondylosis is therefore a possible cause of unsteadiness or dizziness?
Yes, sir.
And cardiologically, you probably must be facing patients who have acute attacks. They have certain hypotension, and the first, with an acute attack of vertigo, there is sweating, there is sort of hypotension and a lot of tension created because the patient might think he's got a heart attack. So do you have patients coming to you as a routine for vertigo?
Many times do come, but if by history you can know that this is intrusive sensitive vertigo, having some rotational sensation, then my job is only just to refer either to your side or to the other side. I can clearly say that type of symptom you know there in the middle of in cardiac situation. But if somebody is coming with dizziness, lightheadedness, or fainting, or pre-syncope, not exactly the vertigo, because by definition in vertigo you have to have some rotational illusion, either for himself or for the surrounding. Otherwise, if he had got pre-syncope or syncope, then definitely I have a role to play, particularly in context of his arrhythmia problem. It is mostly because of bradyarrhythmia or sometimes because of the arrhythmia. It's really difficult if it is the first step. But if he used to have that type of syndrome off and on, then obviously by ECG or by examination we will get something. But if it is the first step, having only minor flow on ECG, it's really a problem for us. Because as you know, the management of that type of patients is by, if it is bradyarrhythmia bypassing, which costs a lot of money. And if it is not cardiac, we put a pacemaker, next month you will come with another syncope with a pointed finger. So it's really a horrible situation for us.
The point to learn over here is that cardiovascular disorders can definitely be responsible for the patient to describe what he feels as vertigo. The point here to be noted is, he said very clearly, if it's true vertigo, then it's not likely to be cardiac. But if it's a sensation of dizziness, unsteadiness, something happening in the head, I feel I'm going to faint. My difficulty, and I have a lot of patients with so-called vertigo coming to me, is I can very rarely get a patient to define the sensation. They give you all sorts, depending on their educational background, the mother tongue, and all sorts of things. They give variety of terms. And for them, everything is vertigo, and that is where the difficulty comes in. Anyway, now what we have established, that all the specialties would therefore be concerned with the patient who complains of, let us say, a symptom of disequilibrium rather than use the word vertigo, where he feels he's not quite well balanced. We'll put it that way. Now, as I've said, the patient comes to you, and sometimes 2, 3, 4 of them may come in one evening. Let me start again with our neurological colleagues. How do you decide, by listening to the patient's history, what are the pointers that tell you, this fellow, I'll put him on Vertil and send him away, and no, this fellow I must look at more seriously. Are there any sort of pointers that you have by which you decide, distinguish between?
Once we have decided that what patient actually is complaining, like once we are sure that it is vertigo, then we go for some other signs and other symptoms. If the patient is also complaining of symptoms, like we have to decide for anatomical localization. That is more important in the history. Like once vertigo is decided, complaint is okay, then we go for symptoms like suggestive of other cranial nerve dysfunction. Apart from the 8th nerve, we go for the symptoms suggestive of other cranial nerves, like involvement of 12th nerve, like patient may be complaining of difficulty in swallowing, he may be complaining of dysarthria, he may be complaining of diplopia, he may be complaining of dimness of vision. So these are the huge pointers which indicate involvement of the brain stem and other cranial nerves. Then again there may be symptoms suggestive of this involvement of the cerebral cortex, like occipital cortex in the form of dimness of the vision, this hemianopia. Then there may be again symptoms like headache, which we can get in some of the illnesses. Then again, if there are symptoms suggestive of orthostatic hypotension, there may be symptoms suggestive of this peripheral neuropathy. So accordingly we go for, we decide, and accordingly we investigate the patient.
So you would basically look for other symptoms suggestive, visual symptoms will immediately put you on guard, headaches will put you on guard. Other cranial nerve symptoms would definitely put you on guard. And then you said peripheral neuropathy. There's one more thing that I would like to add here, which perhaps in my practice sometimes I face. They say that a patient has a brief spell of unconsciousness when they collapse. And this is very clear that if your patient even has a short spell of unconsciousness, then it cannot be ear related. It has to be neuropathy. That's one more point. Visual disturbances is another thing which puts you on guard that this needs to be investigated. Further, and of course other cranial nerve involvement. From the ENT point of view, are there anything? I'm sure a lot of patients come, they sit down and you say, okay, you take this and you come back after 15 days and we'll see. But there are some which you immediately say, no, I think I need to look into details. So, would you tell us?
The thing is, when the patient comes with vertigo, initially I ask whether the patient is having any symptom of the ear in the form of deafness, in the form of tinnitus, etc., or heaviness of the ear. So if that is there, then it pinpoints something that it might be due to some ear disease or benign paroxysmal positional vertigo or Meniere's disease, one of might be. And if it is associated in the very beginning and acute stage in the form of the vertigo and vomiting and along with heaviness of the ears, so that pinpoints something. Naturally, in this way, we will have to investigate, and investigation will depend on the symptoms and my...
No, those we will see, investigation. Only thing is, you feel if there are associated ear symptoms, then you feel you need like tinnitus and heaviness, you said.
Yeah.
Then you would want to investigate further.
Yeah.
I think the first thing is, if this is the first attack or if it's this is one of a series of attacks, because that's very important. If you have a patient who just had a first momentary episode, then maybe that patient you can be a little relaxed. But if a patient had several attacks, then certainly he needs more workup. I think the clue is good questioning, good history. And there are a few questions that I usually ask. Yes, as was already mentioned by my colleague, the associated otological symptoms, associated neurological history of headache, momentary loss of consciousness, but equally some other questions like the duration of vertigo, whether the vertigo is related to any postural changes. First of all, is it a true vertigo? So all these questions, when I have a patient who's had an attack of true vertigo, which has been recurrent or which has lasted for some time, and there is a definite relationship to otological symptoms, I would definitely like to investigate the patient, not just put him on medications and everything.
Okay. The next question is, do you give importance to the nature of vertigo? Sometimes some patients come and tell you, everything goes round and round. Sometimes they come and tell you, something is going on wrong inside my head. At times they tell you, oh, I feel I'm walking like a drunkard, or the ground under my feet is not very steady. Or sometimes they say something is happening but I can't quite describe. Now, they give you a whole variety of symptoms. Would you give importance to the nature of vertigo, or do you feel that's not really important in your diagnosis? Dr. Kalina? Do you feel from your point of view as a cardiovascular person, do you feel that the nature of vertigo gives you a clue?
Yeah, from my point of view, as I mentioned, this type of symptoms usually do not occur. In cardiovascular symptoms relating to diseases, the very important one, as has already been mentioned by everybody, in all specialty properly, history cannot take out anything. You have to have a very important history in cardiovascular, like the deafness or fainting or syncope. In the very fast attack, he may not be aware. But if he has been having that type of attack time and again, he will come to know that this very attack is coming to him. Because the basic pathophysiology, there is bradyarrhythmia. And if the heart does not pump for 20 seconds, the blood does not go to the brain. So cerebrum will suffer. Therefore, we will have a little bit of blackening or darkening or uneasiness, lightheadedness. And the moment he gets that type of symptom, immediately he tries to support someone. Therefore, in cardiac syncope, it is very rare to have injury. So if I have that type of history, I will be put on my head to evaluate that this is very likely to be a bradyarrhythmic syncope. But sometimes, rarely there can be tachyarrhythmia. A patient, in that type of patient, what the patient will give the history. The patient says, suddenly I used to have some palpitation and gradually lightheadedness, then I just don't know. I just don't know. Wait. So this is the type of presentation in fact. Otherwise, if I see that very tachyarrhythmia patient at the time when he is not having symptom, which is obvious, absolutely everything may be normal, ECG may be normal. So that is the only clue that I would get that this is a cardiac.
So transient ischemia is what you're looking at.
Very well.
From the neurology point of view, do you give importance to the nature of vertigo?
As Benita sir has already said, so regarding vertigo, sometimes the patient says the whole environment is moving. Sometimes they will say my head is moving. So these are two subjective and objective evidences of vertigo. When the patient says his head is spinning, that is subjective vertigo. When the whole environment is moving, that is objective vertigo. So these 2 points I do not give that much importance. But again, when the patient says he has got falling tendency, then obviously I give importance whether it is syncopal or syncopal attacks. Then when the patient says yes, he has got clumsiness from walking, these are also the symptoms that they come in those symptoms also. So among the clumsiness of walking, I just try to find out, is it because of cerebellar or is it because of this vertigo? The sense of source of ataxia in vertigo, it lies in the head, while the source of ataxia in cerebellar symptom lies in the legs. So these are the two points which I just asked the patient. The ataxia is because of some problem as if he is feeling some problem in the head, or if he is feeling.
Sometimes you wonder whether it was really all necessary and it's expensive. So, how would you decide what investigations, the sequence of investigations that you do? So let's start with Dr. Kadita first. I think in the orthopedic part, I'll come to you a little later about the thing.
The investigation from my point of view is very simple. If patient from the history, I could feel that this might be a cardiac syndrome or cardiac pre-syndrome. Sometimes the patient may not lose consciousness. Immediately I go for an ECG. We have some data on ECG. Suppose patient shows on ECG severe bradycardia, a heart rate which is less than 40 or 45. Then I am sure 100% that this is 99.9% it is cardiac. Suppose patient is showing LVB or if he comes with complete heart block, there is no other second one. But problem comes if it is a patient of right ventricular block. Suppose a patient of 60 years or 70 years, male or female, at the age of 60, 70, otherwise also we do get right ventricular block in around 20 to 30% patient. Now, whether that very patient has gone for complete heart block and syndrome or it is a just normal RVB, it's really a problem. The next step, it leads to a long list of investigation. The very next investigation. In the rest of the group, we do not go for any investigation. Straightforward, we go for it. In each RVB, or sometimes in bivesicular block, RVB with left-handed block, we go for an Holter. But unfortunately, in Holter, we may get only 20% some findings. Because during the process of Holter, suppose in Holter, we record the ECG. Holter is basically ambulatory ECG. We record the ECG for 24 hours, sometimes 48 hours. But for that very 48 hours, he may be absolutely normal. He may not have any pre-syncope or syncop. But without syncope or pre-syncope also, sometimes you may get long pauses. Suppose for having syncope or pre-syncope, one has to have an asystole of more than 20 seconds. But we may get a asystole period of 3 seconds or more than 2.5 seconds. That gives an idea that this is a patient who intermittently goes for a long pause, long asystole and death. So Holter might give us some help. But if Holter shows normal, that really gives us explaining to the party you go for therapy. Because there is never any list of investigation and none of the investigation give a full proof. The next important, suppose patient cannot afford totally or it will be very hard for him. Then we go for a self, what we can say that it is a self type of Holter. You teach the all attendants and the household persons who will be in and around him. That moment that type of symptom occurs, don't jump for anything else, but just look at the pulse. Teach them how to see the pulse. If that time the pulse is 40, that is the de-diagnostic patient. If during that very episode the pulse is 50 plus, that excludes the cardiac.
How would you decide what investigations?
I think the point has been made by Kadita also that if we decide that a patient needs investigations, then there's no halfway about it. You have to really get a proper evaluation done. From an autological point of view, or a neurological point of view, I would think that essentially we have to have a proper audiology evaluation done. So I would at the least ask for a pure audiogram, an impedance study. I have found in some patients evoked response audiometry to be relevant and useful. We do vestibular tests, and the minimum I think would be a electron hystography, more tests if you have the facilities. And imaging, I think, is something which we cannot rule out. It is expensive, but if you're really seriously investigating a patient with vertigo, then certainly a CT scan is, I think, mandatory in my opinion, because it gives us a lot of information.
And when did you decide to send your patient for a CT scan? What specific things would make you send?
If a patient has had recurrent vertigo and is troubled enough to come and see me, then certainly he's a patient who's going to have a scan. Because by the time he's come to see me, he's seen about...
What are you looking for in the scan?
Well, two things. One, we are looking at the temporal bone, and secondly at the brain. Now, if there is any bony changes, like widening of internal artery meatus, or whether there is any abnormal findings in the inner ear and so on, or whether there is any findings in the brain per se. And if there is any cause for you to really suspect a problem, then I think an MRI also. Because MRI gives you much more information than a CT scan, even though it's expensive. So I think there's no two ways about it. If you really think that a patient is troubled enough to come and see us and he's had problems, and we've decided in all earnestness to investigate this gentleman, we have to go all out. We have to get audiological, we have to have imaging, we have to have proper biochemistry, blood tests, hormonal endocrine tests, all this will have to be done.
Dr. Roger, anything to add to that?
I want to add something that if a patient comes to me with true vertigo, and that will depend on the age of the patient. If the patient is younger, and if the patient is middle-aged or elderly, and if the patient is not having any ear symptom along with the vertigo, and if the patient is having vertigo with ear symptoms, and if the patient is aged, ear symptoms may be due to presbycusis.
No, the question was, what investigation specifically would you do?
In this case, if the patient, younger age group, comes to me with vertigo, and it is deafness, unilateral deafness, and I will think of, say, either Meniere's disease or acoustic neuroma, etc. In that basis, I will go for audiological investigations. I will go for CT scan, and thinking about acoustic neuroma, or MRI, or electroencephalographic examination. All these.
Can I ask you a question here?
Yeah.
Both Mohan and Dr. Rajavi. Out of the patients of vertigo that you refer for imaging, suspected acoustic neuroma, give me a ballpark figure. What percentage of people come back with a positive diagnosis?
Exactly percentage is not possible to say just now.
No, just a rough figure, right? What's your
Not much. If the patient is not having deafness, I don't go for CT scan or only vertigo is there, no other symptoms, no eye symptoms, no headache. In that case, we do not find, about say 30% of patients do not find any cause.
30%?
Yeah.
No, I'm talking about imaging. When you send for imaging for MRI or CT.
No, not 30%. Yeah, that will depend. Very few, not very few.
So
after having all these investigations like audiological, blood and electroencephalography, if you do not find anything, after that we go for it. Or if there is any, already I told, younger patient, unilateral deafness, vertigo, tinnitus, in that case, initially with audiological tests, electroencephalography, I will go for the CT scan or MRI.
What is your impression of patients being sent for MRI or CT and coming back with positive findings, roughly?
Well, it's probably less than 1%, but I will make no apologies for it. The reason is the environment in which we are practicing now. A patient...
No, we will come to that. We'll come to that. Well, I understand. What I'm trying to say is that you don't always expect to get a positive result because...
No, not only that. Well, we are practicing defensive medicine, let's be honest. So if you have not suggested a scan or an MRI,
I was leaving that for...
and the patient comes to you with a positive finding, then you are culpable.
That's right.
So I think there's no apology about it. I think even if it's one person, that one person is very important.
I was saving that for it because I find that patients who come to me through neurologically more often have already an MRI and CT done, and perhaps one of the reasons is that when I talked to them, they said, look, I had a patient. And I said, okay, don't worry, nothing much. And the patient went to somebody else and had an MRI done, and there was a 3 centimeter tumor, but was totally silent. And then the patient came back and said to me, look, so it's one reason to say, fine. The other reason perhaps for which I do it is to put the patient's mind at rest. Because every time they feel a little dizzy, they think, oh God, have I got a tumor? Anyway, going on to you, as Dr. Kanita told us specifically what he will do. So you say, okay, this patient would have a neurological cause for his vertigo.
Tell me what is the sequence of investigations that you do.
If again everything has been discussed, most of the investigations have already been discussed, and the role of neuroimaging we have come to know what percentage only cases, less than 5% of the cases I think I get positive results. 95% of the CT and MRI scans are normal. Only in those cases where a stroke is the suspicion, in those cases yes, 50 to 60% of the cases I get positive result with the CT scan, especially in the cerebral stroke. And coming to the investigations, when a child comes with vertigo, many times you get children with vertigo. In those cases, I go for the EEG of the EEG, and along with that, obviously neuroimaging is being done because the parents are so much worried that they do not leave you without a CT scan of head being done. So that is the only reason why I get a CT scan. Second is the suspicion. There may be suspicion of epilepsy also in there, temporal epilepsy. Sometimes, though rarely present with just vertigo alone, but sometimes children come with vertigo and this vomiting, and then we get EEG and CT scan. Again, young men coming with acute vertigo. I think everything is clear. We know that it is just peripheral vertigo, but still I go for a CT scan of the head. For reasons discussed previously, because one of my patients in whom I refused CT scan, he went after 10 days. He was a teacher by profession. The first time he came to me with acute vertigo. Clinically, I did not take anything. I gave him some medications and I asked him to come after 15 days. But that too, he came within 10 days, and I was lucky enough that he came to me only. And he again insisted for a CT scan. That time also, even I got annoyed. I just told him, yes, you have got money, and you just spend your money and come back with a normal scan. And my surprise, he came with this cerebral as well. And after that patient,
You prefer not to take a chance.
in that case, I was lucky that he came back to me only after 10 days. And after that, in most of my prescriptions, even if in most of my prescriptions, I advise CT scan. Obviously, personally, I tell the patient, do not get it done right now, get it done after 1 month. But I will write in the prescription.
That you are safe. Okay.
For my safety, I will.
Yes, please.
I may differ at this very point because this is not my specialty, this part. But anyway, for any investigations, there should be some logic, particularly for a country like us. See, you may do some mistake in one person. That does not mean the other 99% should go for an unnecessary investigation. We should always go by a probability, a theory by Boyens, who has developed this very theory in 1882. There is a theory of probability. A person coming at the age of 65 with one-sided hemiplegia, our first diagnosis obviously will be a stroke. Whereas a young person coming with that type of thing, the first diagnosis will be heart. Is there something in the heart valve? So I go for an echocardiography rather than CT. Whereas at the 65, I go for the CT rather than the echocardiography. So by probability, particularly in a country, we should not imbibe all the things which has been done in the West. We should do by probability that it is likely to get it. Then we should do it. Otherwise, not even hemoglobin, not even ESL. It may be written in the book. See the probability, see the utility, then spend that very money. I think that everybody of us should be reasonable.
Okay, I think well taken, point well taken, but you wanted to respond to that?
I have told about the children with vertigo, and then coming to elderly. In elderly, obviously, the role of ECG and Holter has been discussed. Along with that, we go for blood sugar.
The biochemical investigations.
Neuroimaging, then carotid and vestibular artery. We investigate for this any vertigo insufficiency for this MR angio.
So let me then ask you the question which I asked them on a similar basis. In what percentage of your patients that come to you, do you find circulatory disorders like transient ischemia or atherosclerotic processes in the cerebral circulation to be the cause of vertigo? Do you think it's a very common cause nowadays?
This atherosclerotic changes in the carotid artery, these are very common.
No, as a cause of vertigo, do you think it is common?
As a cause of vertigo, it is not that common, but routinely I do investigate. For this carotid and vertebral artery.
No, roughly out of the patients who come to you for vertigo, very rough figure, what percent would drop into this group of
vertebrobasal insufficiency or very rough figure?
PPI is 10 to 20% of the patient.
But that's not a small amount. If you say 20%, then not a small amount. Because of the longevity now, you see people are living longer, so this group of vertigo we are seeing also more and more common. Coming to the orthopedic part, would you enlighten us as to what are the mechanisms in spondylosis? Is it only cervical spondylosis that can give rise to disequilibrium, or does a patient with a low backache also have the possibility of suffering from disequilibrium? And what are the mechanisms which are involved in producing this symptom, if you can get us there?
Probably the mechanism of producing this vertigo in related group of patients, particularly elderly or 50 plus people, are probably more than one. Number one is, yes, atherosclerosis is a common occurrence in everybody, but that per se would not produce vertigo. In him, maybe some other factors are playing a role. Notably, one thing that is little underplayed is the problem of cervical myelopathy. Cervical myelopathy is a condition which contributes a lot to this symptom and possibly produces a symptom where the atherosclerosis also has set in. So that both together plays some role.
Okay. What about muscle spasms?
Muscle spasms usually do not produce cardiovascular insufficiency.
No. Producing a symptom of disequilibrium. I've never said not vertebrobasal insufficiency. We're talking about cervical spondylosis. What are the mechanisms by which spondylosis produces disequilibrium? And is it limited only to cervical spondylosis?
There are things like some people say that in certain positions, for example, a person will have vertigo in case of cervical spondylosis, a certain positional vertigo. Say he rotates his head to the right, looks up, and then he gets the vertigo. That is decided, probably we get into the possibility this is a cause where there is some kind of thinking on the particular artery or some other place which is producing this.
So you don't think it's more neurological, you feel it's more vascular than cervical spondylosis produces? Thinking of a vessel or something else?
Thinking is a factor, cannot be the answer to all the cases.
Okay, Mohan, anything to add?
Well, I beg to disagree a bit. I have my own reservations about this vertebrobasal insufficiency diagnosis. I tend to think that it is a convenient diagnosis for us, simply because we can dump a lot of patients into that category. We don't have a diagnosis. I certainly think cervical spondylitis is an extremely common problem. But what percentage of them actually do have vertebrobasal insufficiency? It will be very difficult to establish because we don't have any evidence really which can conclusively point to us. There are some patients, without doubt, who would definitely relate it to the neck, and I'm sure they have true problems. But by and large, the vast majority of patients who are diagnosed with cervical spondylitis with vertebrobasal insufficiency, there's very little evidence to suggest that. Now, as far as the diagnosis evidence-based medicine is concerned, I think it's a very uncommon situation. True kinking of vessels or spasm of vessels and so on is an extremely difficult situation. There was one very important teaching that I had when I was a registrar by Gibson, who is now in Sydney, and he was a consultant in London, and he used to say that a patient who gets vertigo when he's lying down has positional vertigo, benign positional vertigo, and a patient who has vertigo sitting up has got vertebrobasal insufficiency. I think it's still a very useful orthostatic finding.
One question now, doing the rounds, and then we'll talk about therapy. Dr. Roy Chaudhary, in your practice of vertigo or equilibrium disorders, in what percentage of patients, and I want a very rough figure, do you come to a diagnosis, and in what percentage of patients is it that everything seems normal, I don't know what the diagnosis is? And in those patients that you do come to a diagnosis, from the autological point of view, what are the common diagnoses in order of occurrence that you get? What are the conditions which you diagnose?
As I was telling that in about 30% of patients of vertigo, I usually cannot come to a conclusion what is the reason for that. And what I see that about more than 60-65% of patients of vertigo is having a psychological disturbance. Whenever they come to us, they never come alone. Then secondly, benign paroxysmal positional vertigo that I get. Then, as I was telling, most of the patients, about third of the patients, I cannot come to a conclusion. And other patients in the form of cervical spondylosis, as we were talking, if the patient is elderly patients, and definitely cervical spondylosis should be considered. And few months back, we had a discussion whether the cervical spondylosis is causing due to osteophytes pressing onto the vertebral artery or not. That becomes a matter of discussion.
So that point we've covered. I just want to know the diagnosis of autological conditions.
Cervical Meniere's disease,
BPP.
Benign, yeah, BPP. Then your cervical spondylosis. That comes to us. Usually those patients goes after we refer the patient to the orthopedic surgeons, because they do not go initially to orthopedic surgeons. So these are the three cases. And other cases are varying, say labyrinthitis, maybe acute or chronic labyrinthitis, and orotoxic labyrinthitis is not very common. They're not very common. So these are the...
What about your experience in the diagnosis, and what percentage are you left high and dry not knowing what is happening?
I think about 3/4, I agree with you, about 3/4 of the patients you can come to a reasonable diagnosis. The number one category of patients that I see with vertigo have benign positional vertigo. Meniere's disease also a good number. I do see a lot of small problems, and I do see patients with autosclerosis with secondary nephritis. It's fairly common in the south. We do see patients with migraine, with variants of migraine presenting with vertigo as part of the order. And certainly, I think CSOM is now dying out as a cause of vertigo, but we do see now and then a few patients with cholestoma coming also with labyrinthitis.
How often do you diagnose vestibular neuronitis?
Not very often, because we don't get that typical classification of patients now. It's not very common.
Ototoxicity also not very common?
Not very common. Fortunately, all these things are now, I think, on the way out. As is cholestoma, even that is very uncommon now.
Fine. Then a question to our neurology colleague, Dr. Chobe. Can you just highlight for us the three conditions which I want you to tell us a little about? One is very often migraine can present as vertiginous symptom. So how do you determine that this is migraine and not a labyrinthine vertigo? That's one thing. The second thing, you mentioned something about benign positional vertigo in children. Now this is an entity in itself, BPPV of childhood. So a few words on that. And lastly, for the benefit of us ignorant ENT surgeons, temporal lobe epilepsy, what are its classes? Like when do you suspect a temporal lobe epilepsy? What type of a patient? Could you just tell us? Migraine as against a vestibular vertigo. You know, migraine itself may present as a vertiginous symptom. There is vomiting, so people feel, oh, this is vertigo. And what makes you diagnose that, oh, this is migraine? How do you confirm that?
Migraine as such is very common in our clinical practice, accounting for almost 25 to 30% of the cases of the headache. It is a very common. And migraine presenting as vertigo, that is also being seen out of 100 cases of migraine, only 5 to 10% of the cases we see that the patients also component of giddiness and vertigo, and it's not that common. And so, what is the exact question?
When a patient comes to us with vertigo, is that one possibility is that this is migraine presenting as vertigo. So as a neurologist, I wanted you to tell us that look for this, and then you know it's migraine and it's not.
Especially in basilar arterial migraine, that is a term in which we get vertigo is the major manifestation. And here the patient gets vertigo, soon it may be preceded or it may be followed by a severe episode of headache. And then we come to a conclusion, then we think that he might be having basilar arterial migraine. Basilar arterial migraine is not that common. Of all the migraine, it accounts only about 5% of the cases of migraine. So when there are patients of migraine, patients of vertigo, they complain headache, preceded by or followed after. Then we consider migraine as a possibility.
The second thing was temporal lobe epilepsy. When do you suspect?
So temporal lobe epilepsy, yes, such it is a huge subject, and temporal lobe epilepsy, any patient, like whenever he comes with symptoms of unawareness of the environment, patient is all right, suddenly he will start staring, he will make some abnormal movements, finger movements, lip making, he will stare at someone, he will roam around, he will do some abnormal movements, and after 5 seconds, 1 or 2 minutes, again the patient becomes normal. So these are the instances.
And do they also complain of the vertiginous symptoms?
Vertiginous symptoms, again, it may be there. Temporal lobe epilepsy, again, 5% of the cases, they come with vertiginous symptoms. But vertigo alone is not a symptom of epilepsy.
That is associated. Is there any loss of consciousness in this?
Yes, there is always loss of consciousness. The patient is unaware of the environment. He may become unconscious, but often it is seen that the patient he wanders alone. He is unaware of the environment. Unawareness is the most important characteristic. And vertigo alone is never a feature of epilepsy.
Now we come to the last question from my side. And benign positional vertigo of childhood, is there a disease entity like that? BPPP of childhood. Okay, I think we'll go to the next question, and that is now the treatment. I just want a very specific answer. A patient comes to you with acute vertigo, you're called in for acute vertigo, the patient is spinning. What treatment do you institute? And when a patient comes to you with chronic vertiginous symptoms, like it may be many years of BPPP, chronic vertigo, which may not be having vertigo at that moment of time, what drugs do you prefer? Just give me the rationale. In acute vertigo, I think it is better to give injection of, what is that called? Stimulant. And because there is no other drug available to give relief to the patient immediately. Then after that, we can go for integrated balance therapy in the form of giving both synergy, vitamin together, and giving the patient, advising the patient to restrict the excessive salt. So medication-wise, basically injection stimulant. Yeah. Okay. And in a chronic vertigo, like in chronic vertigo, integrated balance therapy, as I was saying, that means drugs and combination of drugs in the form of sinarrazine and beta-histine would be given, and that gives much better. You prefer to combine beta-histine and sinarrazine both together? Both together. Both together. Why is that? Because that it has been seen that by giving both these drugs together and asking the patient not to smoke, and that gives better result than by giving one drug, like the beta-histine or synergy.
In acute vertigo, first thing I do is to admit the patient. And the most important aspect is, first of all, to give an anxiolytic. So I give prochlorperazine, which is stomach injection. But equally, we sedate them with either diazepam or alprazolam, something to calm him, to rest him down, and reassure them that things are going to settle down. I do start them on either beta-histine or sinarrazine. I don't put them together, but equally both of them are effective, but important thing is to stress.
Any reason why you don't have both of them together?
Well, there is this offbeat chance of one being an histamine analog and another being an antihistamine, although it is a central action and it shouldn't really matter. But, you know, it's an intentional therapeutic incompatibility, so you have to think about it. But end of the day, one situation where if a patient who's had a chronic vertigo coming with an acute attack, in such a situation, particularly in Meniere's disease, one has to think about diuretics. It's not effective in that situation. So I do give them Lasix, furosemide tablets for 2 or 3 days to dry them out, and it's quite effective in controlling very severe vertigo.
Meniere's, diuresis and salt restriction.
Salt restriction does happen. Now, there are 2 things I want to just remind the crowd, and that is drugs which have been forgotten, or maneuvers which have been forgotten. One really effective maneuver which we had for an acute endolymphatic crisis was cervical sympathectomy or medical cervical sympathectomy, which really worked. And the other drug which really worked in acute vertigo in Meniere's was steroids. We don't use it now very much, but both of them are pretty effective for very refractory cases. And I still would consider steroids at the back of my mind if a patient has got acute exacerbation of vertigo. But prochlorperazine and anxiolytics would be my choice.
So whenever a case of acute vertigo is admitted, first and foremost is that I just adequate hydration of the patient, because most of the patients are dehydrated. So adequate hydration. Thereafter, the symptomatic relief. So for that, we generally use Stametil injection. And thereafter, avoidance of the head movement and bed rest. These are 2 important factors. And with the Stametil and either of the pitahistine or synergy, either of the 2, I do start. And
what about anxiolite, diazepam?
Yes, diazepam and anti-anxiety. Usually I give clonazepam tablets, sublingual tablets, they are available, and we give clonazepam. And in the same regime, the patient, in the meantime, I investigate the patient. I keep the patients on this regime for 3 to 7 days. And thereafter, after 7 days, generally I try to avoid this pitahistine or synergy.
Avoid?
After 7 days, generally I try to
Why do you try to avoid?
Sir, and after 7 days, generally I prescribe for the exercises. But
do you feel these drugs interfere? Because they claim pitahistine doesn't interfere with exercise. They've got enough evidence to show that.
What I have seen, sir, even long term, if I put the patient for long term exercise,
you feel there is no purpose?
There is no purpose. That's why even only after 5 to 7 days, or I try to avoid pitahistine.
Okay, so I think we're coming to the close. Before I just ask the audience if they have any questions, are there any points from the panel which you feel need to be made from each respective speaker, which maybe have not been covered in my question?
There is, we have already discussed about cervical spondylosis causing vertigo. I think this is a very much overdiagnosed condition, and the diagnosis should be restricted. Cervical spondylosis as such, I do not consider in my clinical practice as the cause of vertigo. Only vertebral basilar insufficiency, that too in elderly group. Usually, I can see so many patients in the age group of 20 to 40. They come, they will say that, sir, I have got cervical spondylosis and also I have got vertigo. They themselves they give the diagnosis, and generally I do not consider that diagnosis as the cause.
So putting those big collars on them is...
So that is the, I do not consider that cause
What do you think there is a mechanism? What do you think there is a mechanism where they say, if I turn my head suddenly...
If this gross, this cervical, this atlantic dislocation or any this craniovertebral abnormality, that is acceptable, but only cervical spondylosis and muscle spasm causing this vertigo, generally I do not accept. And her second point is psychogenic vertigo. That is again overdiagnosed condition. Many patients, sometimes in case of chronic vertigo patients, generally we find that because of vertigo the patients become this psychic.
So we don't know which came first, the egg or the hen.
So that is a very much difficult condition.
I can understand, because
otherwise active person, if he suddenly gets an attack of vertigo and he finds he can't even walk, he is going to be upset. Okay.
So that is again overdiagnosed condition also, and diagnosis of psychogenic vertigo should be made only if there is a clear-cut psychological disorder associated. We must try to find out whether the patient is having psychological disorder or not. If the patient has got psychological disorder, most commonly anxiety neurosis, in that setting only we should go for that diagnosis.
Any other point which you would like to make?
There is a misconception among the people and most of our doctors that hypertension leads to a vertiginous symptoms. And in one way we are fortunate because many of us, many of the people, even many of the doctors do not have a habit of checking our blood pressure. And thereby they do come to us and we get the blood pressure checked. But there is a problem, little bit of problem. Suppose somebody is having vertigo or vertiginous syndrome, vertiginous symptom, they go to a doctor, get a blood pressure of 150 by 100 or 160 by 90. And they attribute, even good number of our doctors attribute that hypertension is the cause of this very symptom. It is not so. Blood pressure is a psychosomatic disease. Moment a patient has got vertiginous symptom, blood pressure, if that blood pressure is 130/80, it is bound to go to 160/100. So never consider and treat that very blood pressure when somebody is having that type of symptom. Because we should treat hypertension when the blood pressure is at the basal level. And basal level blood pressure in true sense is the blood pressure when it is recorded right at the bed, early in the morning, before having a cup of tea, in fact, before getting down from the bed. That is not practical. If it is not practical, what is the practical way? Let the patient come to your chamber or in the OPD. Let him sit down there, cool down, ask him, does he have any other symptom? No symptom is there, particularly vertiginous symptom. Then record the blood pressure. The day when he had symptom, he may have hypertension. Never treat him. Even if it is 100, don't treat him. Let him come after getting that very relief of symptom. Give some drugs as doctors has mentioned. Let him get relief of that very symptom. Then see the blood pressure. Obviously, 99% patient will get normal blood pressure. So that is a misconception that blood pressure. Never ever hypertension leads to vertigo.
Okay, so thank you. Anything else? Wow, please.
Regarding vertigo syndrome, as you are asking, there is a question, as I was going to tell, that some of us was telling that osteophytes in cervical spondylosis has got no effect on vertebral artery. The vertebral artery lies in the transverse processes and osteophytes lie most medially. And what is your opinion? I was actually not being able to understand why. Most of the time, vertigo elderly patients, we go for X-ray for cervical spondylosis, epilateral as well lateral oblique views to see the osteophytes encroaching into the vertebral artery vertebral foramen or not. So I think the two factors should be considered for vertebrovascular syndrome or cervical spondylosis causing vertigo. That is, one is elderly patient atherosclerosis, the lumen has become narrow, and as well as osteophytes pressing onto the vertebral artery, giving further further pressure onto the lumen, thereby lessening the supply of the blood. So what is your opinion? Would we go for
three things I would like to say.
cervical spine or
one is, talking about the psychological aspect. I used to run a vertigo clinic where we found that when we were running a clinic and I had a neurologist, a physiotherapist, audiologist, everybody sitting together, my patients came for follow-up much more regularly because they were taken in, a file was removed, they were given importance. Many of them came feeling better. The drugs we were using were the same. I think what we were giving the patient was a reassurance that we are taking his problem seriously. Now there were some who were refractory. In spite of everything, they were not improving. And I had a psychiatrist sitting with me. We didn't tell the patient he's a psychiatrist, and we said, look, he's going to talk to you. I referred him 40 such patients for a period of 1 year. And not surprisingly, he came back with a diagnosis in all of them. I mean, even if you and I go to him, he'll give us a diagnosis. The psychiatrist has a diagnosis for everything. But the point is, out of these 40, 37 or 38 came back after sessions with him, saying that they felt better. Which means it was more anxiety related, and I think it's not psychological disorders as such, but even anxiety. And perhaps the most important treatment in many of these patients is reassurance more than anything else. And that somebody is taking me seriously, somebody is looking after me. This is one. The second point about the blood pressure. I think many times we get patients saying, I have low blood pressure and that's why I get vertigo. And very often the GP says, I was called middle of the night, patient will have vertigo, vomiting, I took the pressure and it was 90/60. I think if it's a true vestibular attack, you do get a bradycardia, you get a drop in blood pressure, and the GP then attributes the low blood pressure causing the vertigo. I think it's the other way about it. It's a vagal stimulation that's leading to a drop in pressure. As regards your point, I think osteophytes pressing and kinking the vertebral artery, I think is a very unlikely. It may happen in an occasional case, but I think it's very unlikely. It's probably the atherosclerotic disease in the arteries which is leading more to symptoms and not. Are there any questions from the audience which you would like to ask? Besides, when are you stopping? That question will come soon.
So one point is regarding causes of vertigo in pathology practice. So we see a lot of patients with sudden descent deafness. Could be vascular cause of vertigo, presenting with acute vertigo. I think that is one.
Sudden deafness and vertigo together.
Because the patient presents with vertigo immediately. He realizes about the deafness a day or two afterwards when the vertigo is subsided. So it cannot be labeled as Meniere's or which we cannot label as Meniere's also because it's only a single attack and the patient may have
Let me get that question correctly. A patient presents to you with sudden vertigo, and then you treat the vertigo and you realize that he's also got a sensory neural loss, which has not recovered.
Yeah, with profound hearing loss or something like that.
Dr. Roy,
I think it is due to viral pathology. Viral infection might give rise to viral labyrinthitis as well as sudden loss of hearing. But most of the time we see, I personally feel that patients with sudden loss of hearing usually do not get vertigo. That is my feeling. But if at all they come with vertigo, with sudden loss of hearing, that might be due to viral. And spasmodic also may be explained, the spasmodic blood circulation. So these two factors, one is either vertigo due to viral infection or due to spasm of the cochlear artery.
Want anything to add?
Yeah, I just wanted to just make one little observation. We do in our center a fairly good number of endoscopies of CTI, and we do find in not a very big number, but in some patients with vertigo, particularly in refractory positional vertigo, vascular loops which come in contact with the eighth nerve. And it's now more and more a defined entity. So not all positional vertigo is due to canal lithiasis. There's definitely a possibility of vascular loops it's a very crowded area. Vascular loops forming contact with acoustic nerves is known. Now, as far as your point about the vertigo and sudden deafness is concerned, one of the more common causes or probable causes is an autoimmune mechanism. It's being increasingly recognized, which is why there is very good response to high-dose methylprednisolone in many of these patients. So autoimmune is increasingly being considered as a cause of these sudden episodes of hearing loss. Some of them associated with vertigo.
Okay, Dr. Javed.
One more differential diagnosis, then is stroke. That should also be considered in both cases when it is vertigo and sudden deafness.
By stroke by way of a vascular occlusion. That is what he said, that it could be just a blockage. Whether it's spasm, whether it's a thrombus or an embolus, we don't know, but there is an occlusion. The only thing is these patients, the main line of treatment, if you see the literature, is high-dose steroids and try to reverse whatever inflammation there is over there. It's impossible to predict in these cases which patients are going to recover and which not.
I think the minimum that you would start off will be at least a gram of methylprednisolone intravenously. And often you'll have to go to 2-3 grams in a day, minimum. There's no use in giving 500 milligrams, 250 milligrams, and things like that.
5 milligrams 3 times a day.
That's right. That's more like 1 gram. But we start off with a good dose, and there is absolutely no fun in putting them on oral steroids. Because unfortunately, almost all of us do that. ENTs, we don't teach our juniors. So somebody comes with sudden hearing loss, 10 milligram prednisolone TDS, 20 milligram prednisolone TDS, it's chicken feed. It's absolute chicken feed. And the first 48 hours is the golden window that you have, a golden window of opportunity. If you are going to treat him with at least 2 grams or 3 grams of ethyl prednisolone in 24 hours in the first 24 to 48 hours. Otherwise, you're just wasting your time and you've taken away this opportunity for recovery of whatever function.
You know, you have steroid therapy, then you have high dose steroid therapy, and you have mega dose steroid therapy, and this is what you call industrial dose steroid therapy. Okay, I have one more question from the audience. Given a patient of chronic vertigo, they want a take-home visit. What is your drug of choice for vertigo patients? What do you normally prescribe for your patients?
In chronic vertigo, already I told that I follow the integrated balanced therapy. That means I give both the drugs, betahistine and sonorizine. Assurance is definitely I give very early. Then I advise the patient not to smoke and to avoid salt as far as practicable and water. Then I go for the exercise.
So basically the question is what drug? I think somebody has to take home message. So drug is betahistine and sonorizine combination.
Both together.
Mohan?
If I'm convinced it's an endolymphatic hydrops or Meniere's disease, I give betahistine. All of the chronic vertigo, I give sonorizine. So I give both drugs.
Why is that? I mean, why?
There's probably a very slight difference in that betahistine has, as you said, a chance of allowing adaptation, and also it seems to have some specific benefit in Meniere's. But in all of the chronic vertigo, I am very happy with sonorizine. So I give both drugs.
Does sonorizine affect adaptation? You talk about betahistine.
Well, no, I don't think so. Actually, it doesn't. But the betahistine has got a track record in Meniere's. So you do that. But sonorizine is a very effective drug in all forms of chronic vertigo. And of late, I have been using sonorizine in Meniere's disease also very effectively. So I don't even believe that.
Sometimes I get patients who say that, I get an attack of vertigo, I just take 1 tablet of Vertin and I'm all right.
Yes.
And I don't try to but then I would rather say to them, that's fine, that's not the field. Just carry on with that, rather than tell them, look, that's not how it works.
That's right.
Okay. Anybody else would like to just give them a guideline as to what is your drug of choice?
Along with that, in case of chronic vertigo patients of uncertain etiology.
That's right.
In those cases, usually I give sertraline. I get very good response, and that is one of the reasons why most of my chronic
Sorry, I didn't get you. You give what? You give them?
Sertraline, which is an antidepressant. Exact mechanism of action in vertigo I do not know, but it acts very well. One can try starting as at low doses. 50 milligram tablet, 1/4 of the tablet you can give for 3 to 4 days, then half tablet for 3 to 4 days, and then you can come to 50 milligram tablet daily. We can try for 3 to 4 weeks and we can see the response. In my practice, I am getting very good response, and I'll advise others also to try.
The other question before we close, both of you mentioned using sonorizine and betahistine. Now, sonorizine is available in 2 strengths, 25 and 75. Betahistine, Vertin for example, is available in 3 strengths. You have got the 8 milligram, you've got the 16 milligram, and now you've got 24. They say that 24 you can give it twice a day and you get blood levels. What is your choice? Will you use 8, 16, 24? Do you use 25 or 75?
That depends on the condition of the patient. If it is very acute, I go for a high dose. So 24 milligram thrice daily, or twice daily, or 16 milligram thrice daily. And in the chronic stage, I go for the 8 milligram thrice daily.
Why?
Yeah, but betahistine, the minimum you can start with is about 16 milligrams TDS or 16 milligrams twice daily. There's no fun in giving 8 milligrams to start with an acute vertigo. Sonorizine, if it's an acute vertigo, I would start with 75 milligrams. But
The moment this settles down, I would go down 25 milligrams twice a day. Usually that's what I do.
Do you find any kind of sedation with either of these?
Well, I think Cinnarizine sedation is a bit overstated. There's a lot of fear initially that Cinnarizine was causing a lot of sedation. But now there are excellent studies which show that the sedation is really not fine. Of course, you'll always find an odd patient who does complain, and in which case, fine, fair enough. But I think it's a bit overstated.
Okay, if anything to add, or shall we? Any other
I
questions?
just wanted to ask the panelists anything about ginkgo biloba. Do they?
Okay, fine. Which is after his question.
Migraine is a very common, and we feel that some cases we get alternate vertigo in headache. What is the source of the drug?
Alternate?
Migraine.
Yeah.
Headache is also there, vertigo is also there. Alternately, what is the source of your drug? Whether it is like calcium channel blocker or other drugs?
Flunarizine would be a better choice. The question was to get patients with migraine which have sometimes vertigo, sometimes headache, and what to do for that. And the answer to that is flunarizine would be a better drug to use.
If the vertigo is the predominant, then the vertigo is predominant.
I think the mechanism of action of Cinnarizine and flunarizine are the same. So this is sufficient, I think.
Because one knowledge that you are giving some carbamazepine or choice.
Carbamazepine.
For migraine, generally we do not give carbamazepine. Obviously, valproic acid that is being given. Valproic acid is being given, but again, valproic acid is not going to help in vertigo. If the patient has got predominant vertigo symptoms, then but if vertigo is because of migraine, then obviously it will be with any anti-migraine medication like we can give beta blocker, we can go for flunarizine, we can go for valproic acid. So migraine will be treated and accordingly vertigo will be sufficient. But if vertigo is a different symptom and migraine is another symptom, then we can go for this flunarizine. I think that will be the rest rather than going for valproic acid.
Okay, one more question. Go ahead.
What is the most, from you, what is the most choiceable drug? Whether Vitazidine or Cinnarizine, what is the dose you use?
What is the
most choicest drug? The Vitazidine or Cinnarizine? What is the most choiceable drug? Your choice.
Best choice.
Best choice. Whether Vitazidine or Cinnarizine?
No, that has been adequately covered. For example, as Mohan said, if it's a labyrinthine with many years, beta histine, because it is supposed to have a definite vasodilatory action on the stria vascularis. Also, I can understand the patient's reaction with beta histine saying that I get relief from vertigo, because there are trials to show that there is definitely an action on the medial vestibular nucleus, therefore reducing the sensation, subjective sensation. If I prefer beta histine in chronic vertigo, it's only because, like Dr. Roy Chaudhary very rightly said, in my chronic vertigo of non-specific origin, I tend to concentrate more on the adaptation exercises. And sort of somewhere at the back of your mind is the feeling that although Cinnarizine is an excellent drug to give you relief from vertigo, whether it might affect the adaptation is one fear that you have in your mind, because it's an antihistamine. While beta histine, there have been trials to show that okay, it doesn't affect. But I think from the panelists, it appears they're getting equally good results with both drugs. So from that point of view, if I'm going to be giving adaptation exercises, then I would go more for beta histine, because the vestibular system needs to have more suppression when it is going for adaptation. Doc, you had a question.
Sir, I want to number one. In sudden deafness with vertigo, is there any role of cyclin-elect, that is the vasodilator? That is number one. Number two, the incidence of subclavian steal effect with beta has been overstressed. What is your opinion about it?
What is it?
Subclavian steal effect.
Subclavian steal effect.
Vasodilators, I don't give for my patients. There's some point in giving them
blood thinners, like antiplatelet drugs and so on. Cerebral steal syndrome as a part of generalized vasodilatation is a possibility, is a theoretical possibility. Whether it actually happens, we don't know. But there is very little evidence to suggest that vasodilators actually make a difference in the management of sudden deafness. Whereas there is plenty of evidence to suggest that high-dose steroids as well as antiplatelet drugs do make a difference. So I think based on pure scientific evidence, high-dose steroids and maybe antiplatelet drugs to a lesser extent.
One thing that scares you is that when you're giving cycling headaches or you give coplamine on drips, if you run the drip a little too fast, the patient gets flushing. Now when you get flushing, that means all your cutaneous circulation is stealing the blood away. So whether you're really effectively increasing the blood supply to the ear is doubtful. Unless you have something which selectively increases the blood supply intracranially, I think it might be counterproductive. The other question was about the subclavian steal.
Actually, cyclopentolate works on big vessels. So in that case, unless you are having cervical spondylosis leading to vertebral artery syndrome, in that case, cyclopentolate may affect. But in cochlear disease or rare labyrinthitis or Meniere's disease or like that, in that case, it is better not to give cyclopentolate. You can give this synergy or beta-histine if there is no contraindication. And beta-histine has got steal effect, there is no doubt in that. But synergy is not having any steal effect. So it is better if you choose one.
Could you just expand a bit on that steal effect? What exactly is the steal effect?
Well, basically a steal effect is that when you give a vasodilator, it dilates all the vessels. And the vessels which are healthy dilate more than the diseased vessels. So what in effect happens is the blood flows towards the healthier vessels or the non-diseased vessels. And the diseased vessel doesn't get its fair share. Whereas in actual fact, you're giving the drug to reach more to the diseased vessel selectively. So you're actually counteracting your own objective. So a steal effect is something which negates the very action that you want.
So exactly what we were talking about, giving a dose of coplamine.
Exactly.
Where the peripheral circulation steals the blood away and the area you want it to go.
So therefore, when you're giving a vasodilator, the danger is that you may be inducing a steal effect, wherein the blood is stolen from the area where it should go, and it's going to the healthier areas where it doesn't need to go. And it's depriving the affected area even more. Now this is all, there's very little actual evidence for all this. I don't know, my neurological colleague may talk about it, but these are all the fears and the worries that we have. But the actual evidence that we have is vasodilators really make no difference in the management. There's a lot of placebo effect and they have no difference from placebos.
Makes the patient feel nice and warm in the face.
Makes them feel comfortable. Some of them get a headache and
okay. Yeah.
Sir, your opinion about intradependent gentamicin?
There are two things which needed to be discussed, and I think after that we'll close. One was the point that Mohan was trying to make about the use of ginkgo biloba as a drug for vertigo. Any opinions on that from the panelists? Ginkgo bilobas and the like. Do you use it at all?
In case of elderly patients complaining of this dizziness, not true vertigo, dizziness, in those patients, again, ginkgo biloba is also being prescribed for dementia, aging disorder, mild minimal cognitive impairment. So in those cases, elderly patients with dizziness, I prefer to prescribe ginkgo biloba, and we get good responses in that. So that's all.
Okay. Anything?
Regarding ginkgo, again, I would like to say that in those patients of cervical myelopathy sort of patients, they do well with ginkgo biloba. And my experience has not been bad. I would rather suggest that those patients where everything else has been excluded from your side, neurologist colleagues side, and my cardiologist side, then come to me
and there is nothing else to do, I usually do it, and then they are really good on it. Some people at least.
It's a placebo effect or drug effect?
Actually, the reason why I myself was very skeptical about it, to start with. But then there was a BBC program on ginkgo biloba, which ran for 1.5 hours. It was a double series on BBC. And a lot of patients, after seeing that, started coming and telling me that it's got all these wonderful effects, and you tell me you don't want us to have it. And then I realized a lot of patients actually have it routinely anyway. And in the US, particularly, it's marketed as a food supplement, not as a drug. So anyone can go across and buy it in the supermarket and have it. And a lot of patients in Europe are now doing it. It's called Tanacan in Europe. A lot of guys keep popping it in because they think it makes the brain better and things like that. So now a lot of respectability is being given to the drug because of all this media and so on. So that's why, it's very...
No, I could give you some authentic information on this because I did a trial on ginkgo biloba before it was introduced into the market. I'm talking about 1980-81. And I was studying a group of patients, the elderly, and as you know, we used to do craniocopography, where we would do the Romberg's test and we would ask them to do the stepping test. And I had a camera mounted by which I was actually measuring the amount of ataxia. I would superimpose a scale, so I could get the ataxia, the amount of lateral sway, the amount of anterior-posterior sway, in centimeters. And then we would put them on ginkgo biloba for about 6 weeks to 3 months, and then we would repeat this. And I think we were able to show that their stability definitely improved with ginkgo biloba. I don't know what the exact mechanism is, whether it acts on the neural tissue, whether it's anti-atherosclerotic, I don't know what it is. But as he said, it is being really used for people with dementia and things like that. But it seems to add a little bit to their stability, and therefore a lot of neuro-oncologists I know who are treating elderly patients are giving ginkgo biloba on an ongoing basis. That if they just say, okay, take it and don't stop it at all. And what was the other point we wanted to discuss? One was ginkgo biloba, and the other thing we said was intratympanic gentamicin. And for the benefit of orthopedic and cardiology colleagues, there have always been fascination for doing selective vestibular section. So the cochlea and the vestibular system nerves run together, and formally if you try to destroy the labyrinth, you destroy hearing and balance. It has been shown very clearly that in conditions which are vestibular, especially like Meniere's disease, if you knock off the labyrinth, then there are no symptoms. But you don't want to lose the hearing. So people started doing selective vestibular nerve sections. But then it was found that gentamicin is more vestibulotoxic rather than cochleotoxic, and therefore there have been European workers who for many years have been doing this, and this is again coming to fashion, of injecting gentamicin into the tympanic cavity and asking the patient to lie in a position so that the gentamicin sits over the round window, some of it diffuses through, and you can show that the vestibular system with repeated injection dies off, and hopefully the cochlea does not get damaged. It has been an effective way of treating diagnosed Meniere's disease refractory to normal line of treatment with beta-histine or silencing, whatever. But it is my personal experience that if you don't control your dose too carefully, you can get hearing loss, and in effect what you're doing is a labyrinthectomy. And I think it's a little warning, and I don't want to name any people, but somebody presented a paper with 250 cases of intratympanic gentamicin injections done in a period of 1 or 2 years. Now look, I have a slew practice of vertigo. I see about 1,000 to 1,200 patients of vertigo every year. Because anybody and everybody in Bombay who doesn't want that patient says, that fellow, he needs vertigo, you go to him. They just dump their patients on me. And my incidence of Meniere's disease is about 8.2% or 9%, let's say. That means 100 patients of vertigo that I see, which are dumped on me, about 8 to 10 have Meniere's disease. And out of these 10 patients, 8 or 9 will respond reasonably to the drug therapy, diet therapy, reassurance, exercises, all that put together. So it is 1 in 100 that requires some kind of a surgical intervention or might demand surgical intervention. For you to do gentamicin injection on 250 patients. Please calculate that. How many patients of vertigo should you have seen in that time? So when something new comes, don't jump on it just because. I remember the words of Robert Tracy, don't do a procedure just because you're capable of doing it. I think this needs a lot of thought, and it is not as safe as one makes it out to be. So in very selected cases, yes, but think twice before you jump into the patient's here. So I think with this, we close here. I would thank the panelists very much. I think, sir, you have provided us with excellent information today, and I thank the audience and of course the organizing committee for bringing us all together over here. Thank you very much.
Thank you. The panelists will kindly sit there. We have a small formal closure. Sudhakar Chaube is a neurologist from Aditya Hospital, Dibrugarh. He is an upcoming young neurologist. We are very grateful to him for coming over here. Next, I'd like to request Dr. Waterloo to felicitate Dr. Z.S. Borgomai, orthopedician from the Department of Orthopedics, Assam Medical College, Dibrugarh. Next, I'd like to request Dr. Waterloo to felicitate Professor Hamchandra Gupta, a noted cardiologist from Assam Medical College. Dr. Mohan Kamasharan from Chennai. Who have had a wonderful presentation this morning. Even in the panel discussion, we have given a lot of food for thought. Dr. Barin Roy Chaudhary from Kolkata. We had included Dr. Barin Roy Chaudhary, sir, without any prior notice. I'm sorry, sir, you have agreed, you have consented to be a panelist. We are so grateful to you. Thank you, sir. And last but not the least, the moderator, Dr. Milind Vasant Kirtani from Mumbai. So let me once again thank the moderator and all the panelists for taking part in this prestigious multidisciplinary panel discussion. And definitely, I do agree that it was all the audience will agree that it was a very beautiful session. And with this, we come to the end of the second program. I request everybody to be present in the auditorium for a general body meeting. Thank you.
Next. Come to the other part. You know, as Dr. Das mentioned, I established a neuro-oncology department where every year we used to do about, maybe 1,000 or so ENGs, patients investigated. And over a period of years, we built up a database of about 10,000 patients. Dr. Medicare, who was working with us in Bangalore, did an analysis. And we found a variety of disorders. This is just one part of the list. which could be associated, diagnosis which could be associated with a symptom of vertigo, not necessarily presenting symptom. And therefore, not only you had many systems, you had 200, 300 diseases which could produce the patient's symptom. So you said, my God, I have to now go through a checklist of all these diseases. Next. And therefore what we did was, we wanted to find out which direction to proceed, and that's why we designed this history proforma. The advantage is two or three. One, I'm sitting in a busy clinic, patient comes, I've got vertigo, fine. Take this paper, sit down outside, fill it out. Just give me an answer of yes, no. What is the nature of vertigo? What is the vegetative symptom, nausea, vomiting, trigger, etc. The whole history. The idea is I save my time. The patient is happy sitting down filling the form. Secondly, when he comes to me, I only see the points he has ticked off and dilate on those points. So it gives me a direction. Is this cardiovascular? Is this vestibular? Is this cerebellar? I get an idea and I know which direction to proceed in. Thirdly, all the questions that need to be asked get asked. I don't forget something. Very often I have a patient who's had tuberculosis and has taken streptomycin but doesn't tell me because it happened 2 years ago. And the vertigo may be related to that and he comes to me with a CT scan and MRI. But if I ask the questionnaire, I know automatically in the drugs taken that he has taken this medication, the anti-malarial treatment for example, and I get the diagnosis. So I try to reduce my confusion, and believe me, this is very useful. And Dr. Kameshwaran has been harping on one point, medico-legal. Sometimes I had a patient who complained of giddiness. He was a driver, he had Meniere's disease, and we did an ENG, he had frank Meniere, so gave him a certificate, he's unfit. Then he realized that he was losing his job. So he said, no, I am fit. He went to some other hospital and some cold caloric test was done, certificate is fit. I was called to give an opinion 3 years after I had examined the patient. How do I remember? Then I said, no, wait. I took out the history format and I said, look, you had told me that you get swelling sensation. You had told me that with swelling sensation you get vomiting. This was your ENG finding. I'm sorry, but you have Meniere's disease. And Meniere's disease can get controlled, but I can't say you're cured. I cannot say that you cannot get another attack. And therefore, I'm sorry, I cannot certify you fit. So that's the use of the history. Next one. Now, look at the fallacy of things. These are some of the tests which we talked about yesterday. And for the vestibular system, we do ENG. Now, most often I find patients of vertigo coming to me, sir, we have done audiometry, impedance, somebody has done CC also, and don't take it, which nobody does nowadays, and I have done Vera. Okay? But what's your problem? Are you deaf? He says, no sir, my hearing is normal. But he's got all the audiological tests, but the person has not done a caloric test or an ENG. So that is one fallacy of our investigation, that all deaf people did not have vertigo. All people with vertigo need not have deafness. Yet we concentrate on the audiological battery and we forget about the vestibular test. So we said, okay, fine, Dr. Kirtan has written a book on ENG. Should be a very good test. You can get a recording. But look at the fallacy of things also. All these tests, whether ENG or the caloric test in ENG or the rotation test, are tests of extremely low sensitivity and low specificity. Why? Because there are 5 end organs in the vestibular system. You have the utricle, you have the saccule, you have the lateral, superior, and posterior semicircular canal. You do a caloric test and you test only one semicircular canal, and that is the lateral semicircular canal, and then try to make a diagnosis and say that your whole labyrinthine system is normal. No wonder that Dr. Roy Chaudhary was saying yesterday that in 30% of my patients I find everything normal, because we are testing one canal and then saying that the entire labyrinthine system is normal. Also, we know that a variety of factors can affect the caloric test. Therefore, we have to understand that we are doing a very, very gross and non-specific or non-sensitive test to diagnose our patients of vertigo. And from that little information, we are trying to make a diagnosis, and that is the reason why I hate to have these patients. Next. Take, for example, the diseases that we diagnose. Yesterday we asked him, what are the diseases? Meniere's disease, BPPV, vestibular neuronitis, labyrinthitis. Is there even one patient in which you can prove your diagnosis? The only way to prove it would be kill the patient, take out his temporal bone, tell him you got Meniere's disease and I'll cure you. Because today there are conferences occurring all over the world only on Meniere's disease pathophysiology, which go on for 2 days and people are still not coming to the conclusion. Somebody found, like Shuknik found, and it's a very interesting story. How did the diagnosis of eye drops come? There was this neuro-otologist in London, Charles Holpike. All of you know the Holpike test. And there was a young neurosurgeon by the name of Keynes who went across to America. This was in the 1930s. And he learned how to do a selective vestibular nerve section. Instead of gentamicin in the ear, selective vestibular nerve section. And like any young surgeon, whether it's in Assam or in Bombay, you learn a new technique and your hands are itching. I want to do this new technique. He came back to London and went to Mr. Holpike and said, you have so many patients of Meniere's disease whom you can't cure because there was no Vertin at that time. You give me your patients and I'll get rid of their vertigo but I'll preserve their hearing. Sure, sure. Took him on the table, did surgery, posterior fossa, cut the nerve, hematoma, patient died. Did one more case, vestibular nerve section, patient died. Because of infection or what the antibiotics available in those days, 1930s. But they did not lose heart. Out of defeat came victory. They at least had the trouble to go to the post-mortem room, take out the temporal bones, section them, and what they found in those bones was eye drops. And that is how they got the info. They lost 2 patients, but they gave the world the pathophysiology. But is it really so? Because Shuknik in his laboratory in Boston has got temporal bone sections of all patients who die in Mass General Hospital. And he has shown that patients who have had classical history of Meniere's disease for many years, their temporal bones when sectioned, they died of something else, maybe car accident. The temporal bones did not show any eye drops. There were other patients who had never in their lifetime had a single attack of vertigo and their temporal bones showed eye drops. So even the pathophysiology of Meniere's disease, nobody is sure. BPPV, we say, oh, it is these particles that fall into the semicircular canal and you turn the patient over. But as Dr. Mohan said yesterday, that positional vertigo does not always mean BPPV. There are a variety of other things and we put everything into one basket, BPPV, and tell the patient to do adaptation exercises. Vestibular neuronitis, who really knows whether the virus has affected the nerve? There is no way of confirming. And allergic labyrinthitis is because you give steroids and they feel better, so he says, oh, it must have been allergic. So the systems are vague, the tests are vague, the diseases are ill understood. And now we try to treat these patients with whatever we've got. Next slide. And these are the variety of treatments that are given. You give vasodilators, vasoconstrictor, diuretics, you give sedatives, vitamins, histamine derivatives like beta-histine, Vertin, antihistamines like Cinnarizine, you give steroids, all this together. And there are some people who of course put everything together and give what is called shotgun therapy on the belief that something is going to work. Sometimes it works, but you never know which of these has worked. Okay, I know the only place the shotgun therapy works is when you want to get your daughter married. Next slide. Okay, little wonder, then this is what the patient feels like. He's kicked from specialist to specialist. Oh, you look at the thing, patient comes to you with one big file, and you search and see, he's seen the orthopedic, he's seen the cardiac, but he's not seen ophthalmologist. Wait. Check yaar. So you send him off there. And then you see the list of medicines which have been prescribed by other doctors and you find, oh, this particular medicine has still not been prescribed. I tell you what, sir, you try this, and the patient says, okay, and the story goes on. So this is how the patient of vertigo gets treated. Next slide. Now, if you think that I'm in the next 10 or 15 minutes going to give you an answer to all this problem, you are completely mistaken. All that I'm going to say is that I hope to light up in your brain a spark and say, God, I need to look at my vertigo patient a little differently. This I promise you I will do. Next. I was very surprised. About 2 weeks ago, I asked my postgraduate students in ENT, what is the function of the vestibular system? And Pat gave me the answer, sir, balance. One word, sir, balance. I said, that's it, only balance? They said, yes, balance. They're wondering why this guy's gone senile. I think he's now asking stupid questions. Let me tell you, the functions of the vestibular system are 3. One is our orientation in space. The second, yes, is balance control. And number 3, perhaps the most important, is image stabilization on the retina. And I'll talk to you 5 minutes on each of these. Next. Spatial orientation is extremely important. Without spatial orientation, we cannot exist, we cannot function. You've seen pictures of astronauts in space floating about, no gravity, they don't know whether they're up or down. Imagine if you are like that on Earth, how would you do somebody's stability? You couldn't. Even now when I'm talking to you, I know that I'm standing erect because I'm oriented in space, and this orientation to me, in whatever position I am, comes because of 3 systems. My eyes tell me that this is vertical, this is horizontal. The pressure on the soles of my feet is equal, so they tell me I'm standing. If I'm standing on a roof which is sloping, just by the pressure on one sole being more, even if my eyes are closed, I know that I'm bending to one side. And of course, my labyrinth, with the relationship to gravity, tell me that I'm erect. If I do this, the gravity orientation changes, and I know that the orientation is changing. So how I'm oriented in space is also told to me, and it's a very, very important function of the labyrinth. Next slide. Of course, as I said, these 3 do play a part, but the labyrinth is very important. Next slide. I'll give you a simple example. All of us have faced this at times. You're sitting in a train. There's a train on the next platform, and you say, okay, my train is about to leave. You're looking out of the window, waiting for your train to start, and suddenly you feel, okay, your train has started moving. But there is something wrong. Something is not quite right. And then you look out of the window and you say, oh God, it's the other train that is moving. My train is still not started. All of us have experienced this at some time. Now, what happened over here, we have to understand. Okay? And this has got something to do with the orientation. Next slide. We know, or right from birth, okay, that when you're looking at the surrounding, move your head. Move your head and see what happens. You feel the whole surrounding moving. So you have understood in your brain that when the entire surrounding moves, it means you are moving, because the whole surrounding can't move, right? When you're looking out through the window, your vision is limited to that little piece that you see through the window, and for you that is the entire surrounding now, because your vision is concentrating on that. And when that surrounding starts to move, can you just click the next one? Click. Click again. Now go back. Click up arrow. Go up arrow. Okay. Now can you just click the down arrow button? Now go up again. No, just okay, fine. I don't think it's playing properly because I had a little video clip on that. Now, if I take my hand and I move it against the screen, you're seeing the movement of the hand, but do you feel that the environment is moving? No. You know that it's the target which is moving, the environment is telling. So in your brain is a fixed idea that when environment moves, we move. When a target moves, you are steady but the target is moving. What happened in the train was the environment moved and you got the feeling that you were moving, but your back, your buttocks didn't feel the proprioceptive impulse. Your vestibular system did not get the acceleration, and therefore you knew something was wrong. So the vestibular system gave you your correct orientation in spite of the eyes giving you the wrong orientation. And what we learn from this is that even a normal person like you and me, whose vestibular system is normal, whose eyes are normal, if he's faced with a situation where the input from the two systems doesn't match, when the environment moves, you get confused, you feel a little uncomfortable. What then would happen to a person whose vestibular system is not normal and he faces a situation like that? This is something to be understood. Next. Click. And therefore, you get a patient who complains of what is in the West termed as a supermarket vertigo. I don't know whether you have come across. Just click and see whether it plays. Just click that. No, go back. Go back. Go back. Okay, fine, leave it at this. Now, it's not a video film, it's a, hello, Rashid. It's an animation. So obviously the animation is not playing on this. If you have a patient who goes to a crowded place, very often patients tell you that if I go to the railway station, I feel uncomfortable. If I go into a crowded place, I feel uncomfortable. This is a very common complaint. Now what is happening in the supermarket vertigo is that he walks into the place, he's got a labyrinthine vision, and he has this random movement of the surrounding occurring all the time. Because whatever he's seeing, the people inside, there are displays with neon signs going and people are moving right and left. So he sees the whole environment moving, and for him, that is a stimulation that he is moving. On top of that, to correct this image, he doesn't have a normal labyrinthine system. And these are people. Now we very often attribute this to claustrophobia. It is not claustrophobia, it is the environment movement that this patient is suffering from. Next. So what he has got is loss of his spatial orientation in this place where things are moving, and he then is so confused that he tries to express that confused feeling by giddiness, dizziness, chakkar, falling, turning, unsteady, whatever terms he uses. So rather than be irritated with him, try to listen and to read between the lines and listen to what he's saying, and he probably will give you a clue as to what is exactly happening to him. And that is the importance of taking a detailed history. Next one. What he will describe it as depends upon his background, his mother tongue, his way of expressing things. So I'm sure these two people would express it in completely different ways. But listen to them and you'll get the right answer. Next. Now, when the vestibular dysfunction in such a patient is acute, okay, then the amount of discomfort is going to be a lot. So if a patient has just recovered from an attack and he goes into a crowded place or when things are moving, he is going to be very, very uncomfortable. But thank God it doesn't remain like this. Over a period of time, the system settles down. There is central compensation. But it is still wrong to say, oh, don't worry, if one labyrinth is gone, the other labyrinth will take over. It cannot be true. If you lose one ear, you can't tell the patient everything will be fine because you still got the other ear. You lose one eye, you lose depth of vision. You lose one ear, you lose directionality. Similarly, if you lose one labyrinth, you may still be able to balance yourself, but in stressful situations, such as the ones I told you, the patient will still have discomfort. Next. The second part which I told you, this is the control of spatial orientation, which is very important. The second thing is balance control. Okay? And balance control means being able to keep your balance in spite of the fact that your center of gravity does not pass through the base of support. Normally when you stand like this, it's very easy to balance yourself because the gravity passes through your base of support, even if I stand on one leg. Okay? But when you bend across like this, when you reduce your base of support and you start to bend across, if I were to take this microphone and push it like this, it's going to fall down. But I can bend like this and not fall down thanks to my vestibular system. Next. Of course, we know that the vestibular system controls balance because of its action on the postural muscles. Also, by locking the joints, the vestibular system acts on the extensor muscle and it locks the ankle, locks the knee, locks the hip. So when I'm standing like this, I don't have to exert my muscles, my joints are locked. The right side vestibular system controls those muscles which push you to the left. The left side vestibular system controls those muscles that push you to the right. So when you have a fault in one, you tend to go to the other side. Next. You've heard of Tumarkin's crisis, or what is called a drop attack or utricular crisis. These are patients who tell you classically that, doctor, I was sitting at the breakfast table and the breakfast table came and hit me on the face. Or I was standing at the bus stop waiting for the bus to come and the road came and hit me on the face. And you wonder, this guy's gone crazy. And the people who were standing there will tell you, when he was sitting there and next moment he was flat on the ground. He didn't become unconscious. What happened at that time was the utricle or saccule, there was some kind of a lesion there, a sudden lesion, and there was a sudden loss of tone of the postural muscles. The joints got unlocked and he just went across. This is a form of Meniere's disease which is described by Tumarkin. It's called utricular crisis, Tumarkin crisis. But this happened because of the loss of vestibular function which controlled his muscle tone, and he just fell down. Next. Okay, there you are. That if you have the balance tilting beyond the base of support, to maintain your balance, you would have to contract and relax certain muscles, and this is done at a reflex level. At a reflex level, so that you don't have to think, oh, I'm bending to this side, so I must tighten this muscle, by which time you've already fallen down. And this reflex comes not only from the eyes or from the proprioception, but comes from the labyrinth. Next. And in these three reflexes, the labyrinth is the Ferrari. The labyrinth is the fastest because the speed and precision of this reflex comes from the labyrinth. Next. The precision is that even a change in position of half a degree to one side or the other is picked up by the labyrinth, and the speed, because the vestibular nuclei react, that means the labyrinth goes to the vestibular nuclei and to the vestibulospinal tract in as quick as 25 milliseconds, while the visual system reflexes take much longer. So if you have a damage to the vestibular system, next. I can give you a small demonstration of this, and for that I need a volunteer. Would I just try? This is not electroconvulsive therapy for psychiatric disorder. I've got a battery in this, and there's two electrodes. I need a little soap or a little water to do it. These are two electrodes. I've got a little soap water on them to give better connection. Now what I'm going to ask the gentleman to do is to stand facing you. I'm putting the, can you stand with your one leg? Okay. Now close your eyes. I want you to hold okay, my hand will do it. If you tend to fall, don't stop yourself because I will hold you. Okay? I am putting one electrode on his right mastoid, giving him maximum current. Now, when I put it here, ask him to close his eyes. And when I give the current, what I'm doing is I'm changing the resting activity in his vestibular system. And when I touch it, don't worry, it won't be a shock. You just might feel, keep your eyes closed. And when I touch him here, and I put the current on, see what happens. Okay, we'll try it again. Okay, now I just reverse the polarity. I take the negative and positive pole across. I put the other side here, and when I press now, I start the current and see what happens. Now basically, what I did in this was I changed his resting activity. Now he was balancing himself in spite of a narrow base because the vestibular activity on the two sides was equal, so he knew that this is the center of gravity is passing through like this. The moment I changed his resting vestibular activity, he got an impression that gravity is like this. because I gave him more stimulation here on the positive side. And I gave him that, automatically, without realizing, his vestibular system said, I must be perpendicular to the horizontal, I must be parallel to the force of gravity. So immediately the vestibular system tried to adjust him like this. When I reversed the polarity, we went to the other side. We have another example of this with the visual system. I don't know if those who have experienced ever, that you go and stand on the edge of a cliff and you look down. What is the feeling that you get? You feel you're going to fall. Okay? Now I can ask you to stand on the same narrow strip like this on the ground and you will do it without a problem. So it's nothing to do with the base of support. Why is it? Because again, since birth we have learned that when you look at the horizon, what you see at right angles, what you see end on is vertical. What you see at an angle is horizontal. Now when you stand on the edge of the cliff and you look down like this, the ground is now seen end on. And now your visual writing reflex is telling the brain that is vertical. And automatically the whole system tries to make you parallel to the vertical, and you almost get a feeling as if there is an invisible hand behind you which is pushing you, and you take one step back. But if I give you a big parapet in front of you, so that your vision is blocked by the parapet, you don't feel it. So again, the interaction between the visual and the vestibular system. Next. So as I said, the vestibular system is the fastest, it is the Ferrari, and if that gets damaged, then the quickness with which you can change your muscle tone in relation to the stimulus required goes, and therefore these people are likely to have more loss of balance under stressful situations. Next. And these people will typically tell you that when I get up at night to go to the bathroom, I find a lot of difficulty because now the labyrinth is defective, the vision is gone because of the lights not being there. They will tell you walking on cobblestones, walking in sand is difficult, and most of them tell you that walking down the stairs, because the vision also is now getting a little confused, is more difficult. Going upstairs is not a problem, but going down the stairs for them is more difficult. Next. So these are clues that tell you that this patient who comes to you worried, with fear, anxiety, sometimes even nausea and vomiting, which are the results of this bad interaction between the systems, could really be having a vestibular system lesion. Next. And the third function, image stabilization. When you have an image like that on the retina, it is not very difficult to stabilize it. Right? No. Go back. If you have, we talk about optokinetic nystagmus, what is called railway nystagmus. That you sit in front of a patient who's watching the environment going by, and he has a nystagmus because his eyes try to fix that image unknowingly. Or what you call the college corridor nystagmus. This boy sitting in the corridor, and as the girls are passing by, their eyes are going like this. That is visual. So we are under the impression that fixing the object in the center of vision is the job of the eyes. Now, is it really so? Next. I'll give you again a simple demonstration and prove to you that it is not so. I want all of you to look at your finger like this. Come on, give it a try. Go on, do it. Okay? Now, fix your vision on the finger. Now move your finger from side to side. Now like this. Okay? Like. And now go faster. Go faster. Is the finger remaining in sharp focus, or is it becoming a blur? Blur. That means you are not able to maintain it in the center of the vision. Why? We'll see. Now again hold your finger like this. And now move your head from side to side. Is the finger in sharp focus?
Yes.
Why? It's the same relative movement of the finger to the eyes. But when you move the fingers, you could not maintain it because your eyes were trying to keep it in the center. You thought that was the function of the retina. But when you held the finger steady and you moved your head, not only was the finger moving in relation to the eyes, but the labyrinths were also moving. And now you could keep the finger in vision because the labyrinthine reflex works much faster, like I told you, as compared to the visual reflex. And it is your labyrinths that help you keep an object in focus of vision when you are moving, not your eyes. Imagine then a patient who has a labyrinthine system lesion, and when he is walking on the road, and suppose he has to suddenly turn, he is going to have a problem. Next. This is because but when you are doing it visually, next, it goes from the eyes to the lateral geniculate body to the visual cortex to the gaze center, the nucleus paraabducens for the horizontal gaze in the pons, from there to the cerebellum, to the vestibular nuclei, to the oculomotor nuclei, and takes about 75 milliseconds. So if your movements go faster than what the 75 milliseconds can adjust, the finger is no longer in focus. But with the vestibular system, it is 10 times more sensitive. Next. Therefore, when you lose a labyrinth, you lose speed. And there are many people who tell you,
Sir, this when we are moving, that means movement is more than 75 milliseconds.
yeah, the frequency goes beyond that. Now, if you lose a labyrinth, you lose speed, and therefore, when this man is sitting there and somebody calls him, hello, he looks like this, and he feels dizzy. But if he were to look like this, he will not feel dizzy because the speed is what. But most people tell you that if I, sometimes when I suddenly turn my head, I feel dizzy. We say BPPV, not necessarily so. It is a plain and simple labyrinthine lesion which has not been compensated. Next. Next. Okay. Now, we have to realize that the vestibulo-ocular reflex arc is also supervised by the eyes. Now, what do I mean by that? If I look from here to here, the vestibular system makes me adjust, stabilizes the image. Now, imagine I have a defective vestibular system. Therefore, my image stabilization is not perfect. So when I look for Dr. Roy Chaudhary over here, the image wavers a little bit because my labyrinthine system is not proper. But I still need to focus on that image, and after a few days I learn, which is what called adaptation, to focus on that image. Now this is, who tells the brain that what the labyrinth is doing is not correct? It is the eyes. Because when I moved and I focused, I didn't focus on him, so my eyes told the brain, look, he's not focused correctly, he needs to make a little corrective movement of 1 degree more. And when this information is repeatedly fed to the brain learns to adapt the vestibular system, saying, look, you're falling short of the target by 1 degree, so make that extra degree of movement. It's like a shooter. When he shoots at the target and he's shooting little to the left, then they say, no, correct a little bit and shoot to this side. Now this correction of the vestibular system is supervised by the eyes, which tell the cerebellum that, look, the vestibular system is making a mistake. And this is where we talk that this is done on demand. If a patient of vertigo is made to lie many days with his head still not moving, there is no need for the central system to adapt. Therefore, the patient will keep on suffering vertigo for a long time. While if you quickly start him on adaptation exercises, there is a demand that no, the image is not correct, correct it. So on demand, the cerebellum will correct it. And this is the principle behind adaptation exercises. You force the vestibular system to make that mistake, the eyes to correct that mistake and make adjustments. And this is where we say that if you give drugs, like we were talking about Stemetil yesterday, or antihistamines or whatever, they artificially suppress the sensation of mismatch and therefore delay. According to the reports in the literature, they say beta-histine is one drug which does not interfere, and therefore they say in the adaptation exercises this would be the ideal drug to give because the movement is correcting the vestibular system. The beta-histine is giving relief to the patient from the vertigo but not interfering with the adaptation. Next. Now the funny thing is, we know therefore that a defective vestibular system functions best when the eyes are allowed to correct. Yet when we do the caloric test, rotation test, we do it with eyes closed in ENG or in dark. And therefore it is really fallacious that you are testing a system not under optimum conditions and yet trying to make a diagnosis. Next. We know that when the patient is drowsy, when the patient is in darkness, he is changing his nystagmus pattern. This is very simple test. When the patient is being rotated in a rotation test in total darkness, he will not have much of a nystagmus. But now even in total darkness when he cannot see anything, you just tell him, just imagine that Aishwarya Rai is sitting over there and keep on looking at her. And even in dark, when he can't see Aishwarya Rai, just by imagining her there, he will get a beautiful nystagmus. And tell him now that now you keep on looking at your feet. He can't see his feet, but mentally he fixes his eyes on his feet, the nystagmus disappears. So there are so many variable factors in our vestibular test, and yet we try to make diagnosis from these tests about what is happening in this complicated system. Next. Okay? So please try and understand that our vestibular tests are of low specificity, low sensitivity, and therefore in making a diagnosis, you should take their help but not rely entirely. I have a patient who has a classical symptomatology of Meniere's disease, caloric test normal. I can't tell the patient you're normal, go away. I have to treat him on the basis of his clinical picture. Next. For those of you who think that vestibulo-ocular and vestibulo-spinal are the only reflexes that we use, there is another reflex called the vestibulo-colic reflex. Please note that it is spelled with a double L, not with a single L. Okay? Torticollis is when your neck is like this, and the vestibular system acts on the head, because in the human body, the positioning of the head is very, very important. To look at things, it's not only the eyes. Next. For example, if I am standing here and I suddenly see Mohan Kameshwaran there and I want to say hello to him, I am standing like this. This is not how I am going to do it. I am not going to look at him with my eyes and say, hello Mohan, how are you? No. What I am going to do is, I am going to say, oh, there is Mohan. Turn my head. Vestibulo-colic reflex. Turn my head, look at him and follow my head and say, hi, how are you? Now, this reflex is very important, more in animals than us. Have you seen these BBC movies or Animal World movies? They show a cheetah running after a deer. And it's running on uneven ground, jumping up and down. The deer is running like this, and yet the animal is able to keep that deer right in the center of vision. It's not only because of the eyes, it's the steadying of the head. And in spite of all this movement, they say that the vestibulo-colic reflex can keep your head steady within to 3 degrees of movement and keep the target. So in animals, this reflex is extremely important. Next. Go ahead. But I have had an example of this in a patient who had a labyrinthine fistula, and every time you did a fistula test, instead of getting eye nystagmus, he got a head nystagmus like the pigeons do. Next. Just go ahead. Just wanted to say one thing. Okay. This last point and then I'll stop. We know that the stimulation of the labyrinths occurs by movement of the fluid and bending of the hair cells in the cupula. And what we have always been taught is that, let's say in the lateral semicircular canal, when the hair cells bend towards the utricle, you get stimulation. And when the hair cells bend away from the utricle, you get decrease in activity. And because we have mirror images of the two semicircular canals, when I rotate to the right, I get stimulation in the right semicircular canal, and I get equal movement but in the opposite direction, in the opposite semicircular canal. Therefore, the inhibition of activity or resting activity in that canal. That means when I turn, this goes up, this goes down. This is the Ewald's first law, that when the direction of motion is towards the gynocilium, you get stimulation, and when it's against the stimulation, you get inhibition. But the Ewald's second law states that the stimulation occurring in the direction of movement is much more prominent than the inhibition occurring in the opposite side. Which means, when I rotate to the right, the stimulation on this side will be so much, but the inhibition on this side is only so much. Now what is the significance of this? Just click. Go ahead, click. Go ahead and click. I explained this to you. Go ahead and click. Okay. When I have a lesion on the right side, my right labyrinth is not functioning properly. If I move to the left, this is getting stimulated sufficiently, but the inhibition in this is not too much. But still the difference between the two sides is very prominent because the normal side stimulation is as anticipated. So the difference between the two sides is quite good. I feel nothing. But when I rotate to the disease side, I should have got a stimulation by so much, which the brain is anticipating. It doesn't occur. The stimulation occurs only so much. And the inhibition occurs normally. So the difference between the anticipated difference and the actual difference is much less when you move to the affected side. And that is why you have patients with vestibular system lesions that tell you, Doc, when I look to the right, I feel dizzy. If I turn to the left, it's no problem. Even in bed when they tell you, when getting up out of bed, if I turn to the right, I feel dizzy. But from the left, I can get up. And we are still thinking about BPPV of right semicircular canal. May not be so. It is because the lesion side, if you make a sudden movement to that side, the labyrinth cannot catch up. The amount of stimulation expected from the labyrinth was too much. It's not coming. The vertigo occurs. But on the other side, the sort of expected difference was not too much. You got that difference, so there is no vertigo. So this symptom of turning to one side and feeling dizzy could just represent an acute vestibular lesion on the affected side. Next.
Sir.
Yeah.
So whether Reed's Hallpike maneuver will be positive in that?
We'll come to that. We'll come to the question. Okay, so slow movements will not produce vertigo, but fast movements will produce vertigo. Next. So this is what I was saying, that a cyclist riding on a bicycle is going fast and suddenly somebody blows a horn at the back and he turns around. If he turns around to the side which is affected, he will fall down. But if he turns around the other way, it won't be so bad. Next. Okay. So I think we will stop here at this point. I have given you the three major functions of the vestibular system. I think I have given you some food for thought. Can you just go ahead? 1 minute. Just click ahead. Go ahead. Go ahead. Okay. Just to end this by saying that our beautiful presentation on laser showed you the different spectrum of laser. Lovely presentation. I liked it very much. When you pass light through a prism, you break it up into different colors according to frequency. In audiometry, you test different frequencies. Now you test from 250 to 8,000. Why? Although the person can hear from 20 to 20,000, because the optimum frequency is around 1,000, so you test frequencies on either side. So there is something called an optimum frequency. If you look for light beyond these frequencies, ultraviolet, infrared, you can't see the light. So you'll say there is no light. The light is there, you're testing the wrong frequency, invisible frequency. If you want to audiometry, you do it in certain frequency. What about the vestibular tests? Next slide. What the physicists have shown is that the best frequency range in physics for the vestibular system is between 1 Hertz to 10 Hertz. When you do the caloric test, you're testing the system at 0.01 Hertz. You're testing the system with rotation at 0.1 Hertz, while the ideal frequency is here. You know what this is like? Next. Next. Now go back. Go back. So go back, please. Yeah. We do the test in darkness when it should be done in light. We do it below the lower frequency. We test only one canal and make a diagnosis. Next slide. This is like, you meet a friend at a party and says, Doc, I think I'm hearing less. I'm going deaf. He said, no, don't worry, I'm an expert ENT surgeon, come to my clinic tomorrow. You give him a sound of 250. There, you can hear it normally. Fine, your hearing is normal, go back home, don't worry. Well, actually, he has an audiogram next, which is looking something like this. So you're testing only one part, one semicircular canal and saying rest of the system is normal. You're testing it in the wrong frequency range. Next. And that is why I think our vestibular diagnostic today, in spite of all the advances that we have made, is still at a very, very basic level. Therefore, the importance of depending on your clinical history, physical findings, using your clinical judgment, and using your tests only to make a support for your diagnosis or to rule out something. But treat the patient more on clinical grounds than on the basis of the test. So I will rest my case here. If there are any questions, I would be happy to answer. If you're going beyond time, I can answer the questions in the coffee break as you comments. Thank you very much.
Go back with very happy memories. I certainly hope I leave behind good memories also. So thank you once again for inviting me. And as Milind said, it will be a great pleasure to come back and meet all of you anytime when we get an opportunity. Thank you very much.
I am very happy to come over here, and I came several times before also. This time I was so happy that the hospitality that I received from the organizing committee members, especially Dr. Das, Dr. Gogoi, and Dr. Bordoloi and others. It was extremely good, and presentation already mentioned by Dr. Kaptani and Dr. Commissioner. It was really excellent, and I hope that this spirit will be on, and I will be happy to come over here again and again. Thank you very much.
Colleagues and friends, I'm actually very honored that Jorhat Academy bestowed this distinction of asking me to deliver the Academy oration for this year. When the TSH tends to drop. So this factor is utilized in the investigation of thyroid diseases. This is the most important hormone, thyroid stimulating hormone or TSH. The levels of TSH should point directly as to the kind of activity the thyroid gland is having. Next please. So, as far as human beings are concerned, they always had ingestion of iodine in their things. But once they went into being civilized animals, and from nomadic hunters, they settled to an agrarian lifestyle and settled down to places near rivers. Next thing, please. These effects came to occur on the human population. Iodine deficiency, goitrogens in diet, goitrogens from soil, and much later, of course, came goitrogens from industrial wastes. Next. Now, goiter. Any enlargement of the thyroid is called the goiter. Next. And it comes from gutter, meaning throat. It also has a synonym called struma, from the river Struma. It's a river in Bulgaria which flows right through the small river, flows into the Aegean Sea, through Greece. Next. And these are pictures of the population that occur around these endemic areas. You have the whole village suffering, neglected places, massive ones. Very small ones may be imperceptible straight away, but on extension of the spelling becomes prominent. Next. And as far as things are concerned, these endemic areas led to description of whole populations by various authors. William Shakespeare had described people in some areas as dewlap like bulls, clothes had hanging at them. Charles Dickens also mentioning the idiot sunning his big burger. Then Dracula, also Bram Stoker mentions goiter was painfully prevalent in the population of Transylvania. And nearer home, we have Rudyard Kipling mentioning something about a Dhaka physician who paid for his food in ointments good for goiter. Next please. Next. And also there has been a poem on by an anonymous poet on the thyroid for the butterfly, shaped like a butterfly sits in the neck. Next please. And it also found its way into culture. This sculpture from Salzburg, Austria, where here you see a very big goiter here, and this gargoyle, this monstrous thing used for rooftop decorations. And as far as our country is concerned, we have a goiter belt in North India along the South Himalayan areas, which spreads right from Terai regions through the Gors into Assam. Next please. Next please. In Assam, we have found the purpose of my selecting this topic was we have found that Srinagar district tends to have a very high incidence of goiter. Next please. In the town of Srinagar, beautiful place. It's a temple town. Next please. We found the banks of the river Diko. Next please. A large number of cases. This is from a report published from our department in Assam Medical College a few years back. It's a referral hospital. Next, previous one. Find here patients going to Assam Medical College from Tishuka district, Jorhat district, Lakhimpur district, Kolkata, and from neighboring districts of Arunachal Pradesh. We found that Srinagar district had the highest representation. Next. Now, incidence of thyroid disorders in the population. This is something I'd like to mention here that is very high as 60%, though they don't come for detection. Only screening tests may give you an indication that it's so high. And of this, hypothyroidism is somewhat less and hyperthyroidism is much higher. Okay. Now, causes of goiter, large number of causes, of course, the most important is iodine deficiency. Then the others are autoimmune thyroiditis, excessive iodine, the Wolff-Chaikoff effect, or lithium injection, goitrogens, stimulation of TSH receptors by TSH from pituitary tumors, pituitary, inborn errors of metabolism, exposure to radiation, deposition of diseases, these are metastasis, thyroid hormone resistance, subacute thyroiditis, silent thyroiditis, Riddle's thyroiditis, infectious agents, acute suppurative thyroiditis, then chronic infective thyroiditis, the granulomatous diseases, and thyroid malignancy. Next. Development of goiter, mainly iodine deficiency, but most often compounded by the effects of goitrogens and iodine metabolism defects. The next thing. So each of these factors can occur alone or in combination with one or more to produce a goiter. Now the goitrogens, these have a direct effect on the thyroid. That means they can produce a goiter alone, or they can inhibit the normal function of the goiter, or they can potentiate the effect of thyroid stimulators. Next please. Goitrogens, I've already mentioned that they come from diets, chemicals, water pollution, and drugs. Next. Now the dietary goitrogens, these are the sulfurated organic compounds like thiocyanates, isothiocyanates, and thioxazolidines or goitrines. They are found in various foods and are highlighted a few of the foods that are prevalent or taken in this part of the country like turnips, maize, bamboo shoots, very common in Northeast India. Sweet potatoes, because brassica, cassava, and lima beans are dietary things of this part of the country. Aromatic disulfide, this is goitrogen of rats, onion and garlic, not yet proved in man. Then millet, sorghum, beans, flavonoids, soya proteins. Next, then chemicals. We have the various kinds of chemicals. They may be industrial chemicals as waste or geological coming from. Next slide. Then other is the water pollution. Again, industrial excess, calcium excess, chlorine, and drugs. Drugs like sulfonamide, resorcinol, fats. Another thing that will be is cigarette smoke. Contains thiocyanate and goitrogenic compounds like resorcinol, rhabdix, flavonoids, and hydroxypyridones. Next. And these are the list of chemicals that can cause goiter. Next. Now, classification of goiter. Goiters can be classified in various ways. Maybe etiological classification, the morphological classification, or the histological classification. Next. Maybe the etiological is the simple non-toxic goiter, the toxic goiter, the neoplastic goiter, the thyroiditis, and the chronic specific thyroiditis. Next slide. The simple non-toxic goiters constitute the puberty, the physiological goiter, the diffuse hypoplastic goiter. These are diffuse epithelial hypoplasia. This is the histological picture of these goiters. Then the nodular goiter, there will be a solitary nodule, cystic or firm, localized, or multinodular, generalized hyperinvolution. Next. And toxic goiter, the high levels of circulating thyroid hormones, they will be primary or secondary. Next. The neoplastic goiter may be benign or malignant. Malignant will be primary carcinomas like papillary, follicular, medullary, anaplastic, the 4 varieties known. The secondary carcinoma, the deposits from others, and lymphomas, the other malignant variety of thyroid. Next. The thyroiditis, various kinds, again, granulomatous thyroiditis, autoimmune thyroiditis, or lymphomatous thyroiditis of Hashimoto's, Riddle's thyroiditis, and acute bacterial thyroiditis. Next. And chronic specific thyroiditis, tuberculosis, and syphilis. Syphilis is very rare. Next one. Next. The histological classification, you have hypoplastic epithelium in iodine deficiency, Graves' disease, goitrogen-induced disease, and plumber's disease. Plumber's disease, of course, is another thyrotoxic. Then colloid-filled follicles in idiopathic nodular goiter, the anaplastic cells of carcinoma, lymphocytes in Hashimoto's, foreign body granulomas, these decurvens thyroiditis, and fibrous tissue in Riddle's thyroiditis. These are the histological pictures that you may get in the various kinds of goitrous presentations. Next one. These are all the histological pictures only in somewhat more detail. Next one. And of course, the functional status of a goitrous gland can be hypothyroid, where the circulating hormones are low, euthyroid, where within normal limits, and hyperthyroid within their raised. Next. Now, the understanding of thyroid disease, the chronologically and the sequence of events has always been haphazard.
উত্তৰ পূব ভাৰতৰ কাণ নাক ডিঙি বিশেষজ্ঞ চিকিৎসকসকলৰ সপ্তদশ শিৱসাগৰ এই সন্মিলনখনি আজিৰ এই সাংস্কৃতিক সন্ধিয়াত উপবিষ্ট আপোনালোক সকলোলৈ আমি সশ্ৰদ্ধ স্বাগতম জনাইছোঁ। তিনিদিনীয়া বিস্তৃত কাৰ্যসূচীৰে আয়োজন কৰা আজিৰ এই সাংস্কৃতিক সন্ধিয়াখনে আমি আপোনাক সকলোৱে নিবেদন কৰিছোঁ এখন এই সাংস্কৃতিক সন্ধ্যা। এই সন্মিলনখনে চিকিৎসা বিজ্ঞানৰ বিভিন্ন দিশৰ ওপৰত আলোচনা, অস্ত্ৰোপচাৰ আৰু ঔষধৰ সেই বৈজ্ঞানিক জটিলতাখিনিৰ পৰা খন্তেকা কৰি আজিৰ এই মধুৰ সন্ধ্যাটিত, বৰ্ষৰ মুখৰ সন্ধ্যাটিত হাঁহি, ৰং, নৃত্য গীতৰ সেই পৃথিৱীখনত এবাৰ ভুমুকি মাৰি চোৱাৰ প্ৰয়াসেৰে আমি আপোনালোকৰ মাজলৈ লৈ আহিছোঁ সংস্কৃতিৰ ভিন্ন ৰঙৰ সঁফুৰা। আপোনালোকে নিশ্চয় প্ৰত্যেকে জানে যে ভাৰতৰ ধ্ৰুপদী নৃত্যবিলাকৰ ভিতৰত এক অন্যতম নৃত্য হৈছে ভাৰত নাট্যম। শিৱসাগৰৰ উজ্জ্বলতা সাংস্কৃতিক কেন্দ্ৰৰ ভাৰত নাট্যম নৃত্য বিশাৰদ গুৰু নজিবুল্লাহ আলীৰ ইচ্ছা কেইগৰাকীমান প্ৰশিক্ষাৰ্থীয়ে প্ৰদৰ্শন কৰিবলগীয়া এটি ভাৰত নাট্যম নৃত্যৰে আমি আজি এই সাংস্কৃতিক সন্ধ্যাৰ মঞ্চ মুকলি কৰিবলৈ আগবাঢ়িছোঁ। তেখেতসকলে পৰিৱেশন কৰিবলগীয়া নৃত্যটিৰ শব্দম নামেৰে নামাকৰণ কৰা হৈছে। শব্দম ই ভাৰত নাট্যমৰ অভিনয় প্ৰথম নৃত্য। ভগৱান শ্ৰীকৃষ্ণৰ বিভিন্ন লীলাসমূহ এই নৃত্যৰ যোগেদি বৰ্ণনা কৰা হয়। শ্ৰদ্ধাস্পদ দৰ্শকবৃন্দ, এয়া মঞ্চত আপোনালোকৰ সন্মুখত নৃত্য পৰিৱেশন কৰিবলৈ আগবাঢ়িছে উজ্জ্বলতা সাংস্কৃতিক কেন্দ্ৰৰ ভাৰত নাট্যমৰ শিল্পীসকলে। এইমাত্ৰ যে পৰিৱেশন কৰি গ'লে এই নৃত্যটি পৰিচালনা কৰিছিলে ভাৰত নাট্যমৰ নৃত্যৰ গুৰু নজিবুল্লাহ। এইখিনিতে আমি আপোনালোকক জনাবলৈ পাই অত্যন্ত গৌৰৱ অনুভৱ কৰিছোঁ, অতিশয় গৌৰৱান্বিত হৈছোঁ যে উজ্জ্বলতা সাংস্কৃতিক কেন্দ্ৰৰ প্ৰশিক্ষক ভাৰত নাট্যমৰ নৃত্য বিশাৰদ গুৰু নজিবুল্লাহ আজি এই মধুৰ সাংঘাতিক আমাৰ মাজত আহি উপস্থিত হৈছে। সেইজনা মহান ব্যক্তিক আমি উদযাপন সমিতিৰ তৰফৰ পৰা অকণমান শ্ৰদ্ধা জনাবলৈ বিচাৰিছোঁ। এখন ফুলাম গামোচাৰে তেখেতক অকণমান সম্বৰ্ধনা জনাবলৈ বিচাৰিছোঁ। আমাৰ নজিবুল্লাহ ছাৰক আমি মঞ্চলৈ আমন্ত্ৰণ জনাইছোঁ আৰু তেখেতক মঞ্চলৈ আগবঢ়াই আনিবৰ বাবে ডক্টৰ প্ৰদীপ বৰদলৈ আৰু অঞ্জনা সম্বোধন জনাইছোঁ। এয়া আপোনালোকৰ সন্মুখত ভাৰত নাট্যমৰ নৃত্যৰ গুৰু নজিবুল্লাহ আলী। আজিৰ এই প্ৰেক্ষাগৃহত উপবিষ্ট জ্যেষ্ঠসকলক উদ্দেশ্যি মই এটা কথা কৈছোঁ, এটা প্ৰশ্ন কৰিছোঁ। দিনটোৰ কৰ্মব্যস্ততাৰ মাজত কোনোবাই চাকৰি কৰিছে, কোনোবাই ব্যৱসায় কৰিছে, বিভিন্ন ব্যস্ততাৰ মাজত আপোনালোকৰ বাৰু কেতিয়াবা শৈশৱলৈ মনত পৰেনে? সৰুকালৰ দিনবিলাকলৈ নিশ্চয় পৰে। আৰু যিসকলৰ নপৰে মোৰ বিশ্বাস যে এতিয়া পৰিৱেশন কৰিবলগীয়া নৃত্যটি উপভোগ কৰি নিশ্চয় তেওঁলোকে শৈশৱৰ সেই মুহূৰ্তবিলাকলৈ উভতি যাব আৰু সৰু সৰু ল'ৰা ছোৱালীৰ দৰে উমলিবলৈ মন যাব, সেইটো মোৰ বিশ্বাস। শ্ৰদ্ধাস্পদ দৰ্শকবৃন্দ, এইবাৰ আপোনালোকৰ আগত পৰিৱেশন কৰিবলৈ লৈছোঁ আমাৰ এই শিৱসাগৰৰে কেইগৰাকীমান বৰ গুণী বিশিষ্ট চিকিৎসকৰ বৰ মৰম লগা কণমানি কেইগৰাকীমান শিল্পীৰ এই সৃষ্টিমূলক নৃত্য অনুষ্ঠান। আহকচোন, আমি আশা ৰাখিছোঁ তেখেতসকলক আপোনালোকে সম্পূৰ্ণ সহযোগিতা আগবঢ়াব, আমি নৃত্যটো উপভোগ কৰোঁ। হাজৰিকাই কৈছিল যে বহাগ মাথো এটি ঋতু নহয় নহয় বহাগ এটি মাহ অসমীয়া জাতিৰ আয়ুস ৰেখা গণজীৱনৰ ৰেখা বহাগ আহে ঢোলৰ চেৱত বহাগ আহে পেপাৰ মাতত বহাগ আহে কলি কেতেকীৰ মিঠা মাতত বহাগ আহে কপৌ ফুলৰ সুবাসত সেয়া আমি সকলোৱে জানো নহয় জানো কিন্তু সেই বহাগ শিৱসাগৰৰ গাভৰুৰ দেহ মনলৈ কেনেকৈ আহে সেয়া প্ৰকাশ কৰিবলৈ বিচাৰিছে শিৱসাগৰৰ বিহুৱতী গাভৰু পাকিজা ৰচিদে শ্ৰদ্ধাস্পদ দৰ্শকবৃন্দ এই আপোনালোকৰ সন্মুখত মঞ্চত পাকিজা ৰচিদ শ্ৰীমতী পাকিজা ৰচিদৰ নৃত্যটো চাই সঁচাকৈ মনটো কিবা বহাগত থকাৰ নিচিনা লাগিছিল নহয়নে বাৰু প্ৰত্যেকৰে নাচো নাচো নিশ্চয় লাগিছিল নহয় জানো নাচিম আমি পাছত সকলোৱে নাচিম কিন্তু এইবাৰ নৃত্য উপভোগ কৰাৰ পাছতেই আমি আপোনালোকক লৈ যাবলৈ বিচাৰিছোঁ সুৰ আৰু সংগীতৰ সেই মায়াময় জগতখনলৈ সুগন্ধি পখিলাৰ কবি হীৰেন ভট্টাচাৰ্যই কৈছিল যে মাজে সময়ে দুই এটা গান গোৱাটো ভাল নহ'লে জীৱনটো হ'ব পাৰে জঞ্জাল গতিকে আমি আহিবলগীয়া সংগীতখিনি উপভোগ কৰি আমাৰ মনৰ মাজৰ জঞ্জালখিনি আঁতৰ কৰোৱা হওক এয়া আমি আজি এই সাংস্কৃতিক সন্ধিয়াত সংগীতৰ মায়াজাল সৃষ্টি কৰিবৰ বাবে নিমন্ত্ৰণ কৰি আনিছোঁ অকল শিৱসাগৰৰে নহয় সমগ্ৰ অসমৰে কেইবাগৰাকী প্ৰতিষ্ঠিত অতি প্ৰতিভাশালী কেইগৰাকীমান সংগীতজ্ঞ আমি তেখেতসকলক মঞ্চলৈ আমন্ত্ৰণ জনাইছোঁ কেইবাগৰাকী প্ৰতিষ্ঠিত সংগীত শিল্পী এষাৰ কথা আছে শব্দই যেতিয়া হাৰ মানে তেতিয়া সংগীতে কথা কয় এয়া এই বিশিষ্ট সংগীতজ্ঞসকলে আজিৰ এই সাংস্কৃতিক সন্ধিয়াত আপোনালোকৰ লগত কথা পাতিব সংগীতেৰে আমি আশা ৰাখিছোঁ আপোনালোকে তেখেতসকলক সম্পূৰ্ণ সহযোগিতা আগবঢ়াব আমি মঞ্চলৈ গীত পৰিৱেশন কৰিবৰ বাবে আমন্ত্ৰণ কৰি আনিছোঁ কেইবাগৰাকীও প্ৰতিষ্ঠিত কণ্ঠশিল্পী প্ৰথমে আমি মঞ্চলৈ আমন্ত্ৰণ কৰিছোঁ শিৱসাগৰৰ এগৰাকী কণমানি বুলিয়ে কৈছোঁ বৰ কম বয়সৰ ছোৱালী অতি কম বয়সত সৰুৰে পৰা এটি সাংস্কৃতিকময় পৰিৱেশত ডাঙৰ হোৱা নিজস্ব একাত্ম সাধনাৰে ইতিমধ্যে সংগীত জগতত সংগীতৰ এটি ভেটি সুদৃঢ় কৰিবলৈ সক্ষম হোৱা আমাৰ অতি মৰমৰ শিল্পী যি ইতিমধ্যে অসমৰ বিভিন্ন মঞ্চত গীত পৰিৱেশন কৰি দৰ্শকৰ বিপুল সমাদৰ লাভ কৰিবলৈ সক্ষম হৈছে এই মঞ্চত আমি আপোনালোকৰ আগলৈ আগবঢ়াইছোঁ আপোনালোকক আগত গীত পৰিৱেশন কৰিবৰ বাবে মই মাইক্ৰফোন বাইদেউৰ হাতত অৰ্পণ কৰিছোঁ। মঞ্চত গীত পৰিৱেশন কৰিবলৈ আগবাঢ়িছে ইতিমধ্যে অসমৰ বিভিন্ন মঞ্চত গীত পৰিৱেশন কৰি অকল মঞ্চতেই নহয় কেইবাটাও এতিয়া শ্ৰাব্য কেছেটত নিজৰ গীতৰ নিজৰ কণ্ঠৰ নিজৰ আগুৱাই দৰ্শক শ্ৰোতা ৰাইজৰ অতি মৰম বুটলিবলৈ সক্ষম হোৱা ইতিমধ্যে সংগীত জগতত শ্ৰোতা ৰাইজৰ মনত এক সুকীয়া আসন দখল কৰিবলৈ সক্ষম হোৱা আপোনালোকৰ আমাৰ মৰমৰ শিল্পী যাক পৰিচয় কৰি দিয়াৰ কোনো প্ৰয়োজন নাই এয়া মঞ্চত আপোনালোকৰ আগত গীতৰ শৰাই আগবঢ়াবলৈ আগবাঢ়িছে শ্ৰী অঞ্জন শইকীয়া এই মঞ্চত আমাৰ মৰমৰ অঞ্জন দা একেলগে ভাল লাগিব কিন্তু সৰু ল'ৰা ছোৱালীয়ে যদি ঘৰত কেতিয়াবা আমনি কৰে তেতিয়া কয় যে ডাক্তৰ মানে এদিন বেজি দিব তেতিয়া ঠাণ্ডা হৈ যায় হয়নে বাৰু কিন্তু এটা কথা যে সেই চিকিৎসকসকলৰ ভিতৰত যে এটা অতি কোমল অন্তৰ এটা শিল্পীসুলভ মন লুকাই থাকে সেয়া বহুতেই নাজানে সৰু ল'ৰা ছোৱালীয়ে নহয় বহুত ডাঙৰেও ভয় কৰে চিকিৎসকলে শ্ৰদ্ধাস্পদ দৰ্শকবৃন্দ এয়া আমি অঞ্জন আমাৰ নিমন্ত্ৰিত অতিথিসকলৰ লগতে আমি চিকিৎসকসকলৰ সেই প্ৰতিভাখিনিও মাজে মাজে প্ৰকাশ কৰি থাকিবলৈ চেষ্টা কৰিছোঁ এয়া আজি এই সাংস্কৃতিক সন্ধিয়াত আমাৰ মাজত আহি উপস্থিত হৈছেহি চাবুৱাৰ পৰা আহিছে ডক্টৰ মৃদুল দাস আমাৰ মৰমৰ মৃদুল দাস আমি তেখেতক দুটিমান গীত গাই আমাক মনোৰঞ্জন দিবৰ বাবে অনুৰোধ জনাইছোঁ আৰু লগতে এইটো প্ৰতিপন্ন কৰিবৰ কাৰণে আমি নিমন্ত্ৰণ জনাইছোঁ যে চিকিৎসক বুলি ক'লে ইমান ভয় কৰিবলগীয়া একো কথা নাই চিকিৎসকো একোজন শিল্পী এয়া মঞ্চত আপোনালোকৰ সন্মুখত গীত পৰিৱেশন কৰিবলৈ আগবাঢ়িছে আমাৰ অতি শ্ৰদ্ধা আৰু অতি মৰমৰ চাবুৱাৰ পৰা অহা এয়া মৃদুল দা ডক্টৰ মৃদুল দাস গীত পৰিৱেশন কৰিবৰ বাবে মই মাইক্ৰফোন সমৰ্পণ কৰিছোঁ
ডক্টৰ ভূপেন হাজৰিকাৰ গীত গাইছোঁ অলপ গহীন গান এইটো একদম আকস্মিক এক্সটেম্পৰ গতিকে অলপ ভুল হ'লে ক্ষমা কৰিব
শ্রোতা দর্শকবৃন্দ, এইবাৰ আমি আকৌ আপোনালোকৰ আগত মঞ্চলৈ নিমন্ত্ৰণ কৰিছোঁ। আমি নিমন্ত্ৰণ কৰি অনা আন এগৰাকী সংগীত শিল্পী, যি ইতিমধ্যে নিজৰ এক স্বভাৱসুলভ কণ্ঠৰে শ্ৰোতা ৰাইজৰ মন পৰখিবলৈ সক্ষম হোৱা অতি মৰমৰ কণ্ঠশিল্পী শ্ৰীমতী কোন হ'ব পাৰে বাৰু? শ্ৰীমতী ৰশ্মি শইকীয়া। আমি তেখেতক মঞ্চলৈ আমন্ত্ৰণ জনাইছোঁ গীত পৰিৱেশন কৰিবৰ বাবে। আমাৰ নিমন্ত্ৰিত শিল্পী এয়া ৰশ্মি শইকীয়া।
বিদ্যাৰ শুভেচ্ছা যাচিছোঁ। আজি দৰ্শকসকলক খুব ভাল লাগিছে, ইমান সহায় সহযোগ কৰিছে, তাৰ বাবে ধন্যবাদ জনাইছোঁ। আগলৈ যাতে এনেধৰণৰ সহায় সহযোগ পাওঁ।
Dr. Hemant Gogoi. Please come to the stage.
শিৱসাগৰত আহি মানে শিৱসাগৰত আমাৰ পুৰণি বন্ধু বান্ধৱক লগ পাই মোৰ পুৰণি কথা মনত পৰিছে ইমান জমুৱা গানৰ পিছত আমি গাবলৈ অকণমান বেয়া লাগিছে তথাপিতো পুৰণি দিনৰ
খুব জমিব
on behalf of doctors. Now, on behalf of pharmaceutical company, we would like to call Mr. Plavon Bordaloi, who will come. Just he will take about 3 minutes of you. Just 3 minutes.
ঠিক আছে
you go to Simla? So the husband said, no. You see, we went to Simla after going to Delhi. You had it in Delhi itself. You remember we went and attended that wedding over there. And I said, look, how long have you had vertigo? Then they started fighting with him. No, Baba, it was not in Delhi. Remember that meal where finally after 5 minutes that woman turned around to him and said, who is feeling giddy, you or me? You. Then you shut up. But I still had not got the answer. And believe me, this is how it happens. So, don't give your patient a chance to talk. Next slide. Because he will come out with whatever way he can describe. Yesterday we were talking about the importance. Patient comes and says, I've got vertigo. Do you take him at face value? Because what he might mean by vertigo might be a variety of different sensations. And very often, the only reason why we pursue the nature of vertigo is to find out whether the patient really has a sense of motion or it's a mental confusion or fear. That's all. Next. Now, why does this confusion occur? It occurs because, as we know, that the control of balance is not only by your vestibular system, it's an input-output system which has within the eyes, the joints, the muscles, the labyrinths, the brain, the muscles of posture, and of course a variety of other things. If your heart is not pumping blood properly, if your blood sugar is fluctuating, all these things can also produce a sensation which the patient interprets as, doctor, I have got vertigo. So this is why